Okay, hi guys. A very good evening to everybody, and we can get started for today. I missed out a couple of names. Uh, okay, I think it's another 48 hours, less than 48 hours left, and then you guys are gonna be free, and you can imagine. I mean, 48 hours from now, when you are gonna be, smiling, saying, "Okay, great." I'll make it rapid, guys. I'll make it rapid, and let's not waste time. Let's start with the first question for today. Yep, sweet child of mine, great. Guys, I'll not be able to call out names today because I think we should try and save time. So I apologize if I'm not taking your names, but a very good evening to all of you. And let's bring it on, right? In the very first question, this talks about a patient. Hopefully, doc, hopefully. We have this patient who's having a gradual onset motor paralysis with the spasticity. And doctor, I'll try to take about 100 minutes or so, or lesser than that. Okay, sir, sometimes the video resolution can be an issue. Let's wait for your answers there. I am having a patient who's having a pure motor paralysis with spasticity, and this is a question which is a repeat one. I have deliberately slightly modified the options. If you look at amyotrophic lateral sclerosis, it should be having combination of lower motor neuron findings as well as upper motor neuron findings. Guys, as far as I'll just zoom it into the screen. Amyotrophic lateral sclerosis में तो यार there should be a combination of both upper motor and lower motor neuron findings. Screen is, I think, fine. I'll move on. Yep, this is a repeat question. The actual question in the exam in the previous years was he had mentioned a farmer. He had also mentioned that this is a farmer from, yes, doctor, it's a PYQ. The question in the exam was it is a farmer from Chhattisgarh and he is presented with pure motor paralysis with spasticity. Now I had to make it a little shorter, kind of one-liner. So that is why I did remove that statement that it is a farmer and I mean Chhattisgarh thing. The point is why answer is not amyotrophic lateral sclerosis is that there should be features of lower motor neuron lesion given in a question, which is not here. I mean, had this question said about areflexia, etc., then I would have thought. And why it is not Guillain-Barré syndrome? Because Guillain-Barré syndrome will be having classical features of lower motor neuron lesion in the form of areflexia, fasciculations. This would be Boer toxin, exactly right. So the correct answer to the first question is letharism. And yes, I think Dr. Amulya and subsequent people have got this one correct. Doctor, I'll try to wind off in 100 minutes odd. So please cooperate. And what I expect out of you is quick answers there. For those of you who have joined in, I'll repeat the main fact again. Why this is not ALS is because you should be having a combination of lower motor and upper motor neuron lesion, which is not present in this case. I mean, there is no information given for lower motor wear, which is why option A can also be ruled out. And that is why the correct answer here is letharism. And I've already sensitized you to the fact that this actual question PYQ mentioned farmer from Chhattisgarh, so it had a bit of a PSM overlap. We move on to the second question. This says patient is having a short history, fever for 1 day, and CSF analysis was the main objective of the examiner. There was a CSF lymphocytosis with a normal sugar and an increased protein. Now, yep, I'm having two answers in this case, tubercular meningitis and viral meningitis. The point against tubercular meningitis is normal sugar in the patient. So please remember that I agree to the fact that in an Indian exam, the first thought process of yours, every time you get a CSF lymphocytosis is going to be tubercular. But for tubercular, you need a long history. You need, a patient to be sick for at least, 15, 20 days, in a sense that mother will initially say that my child was not eating food. Then she says that, he started vomiting. Then she says that he's not opening his eyes. Then she's saying he's not even recognizing me. Earlier, he at least opened his eyes, looked at the mother. Now he's not even recognizing the mother. So there would be gradual onset manifestations developing in the patient, along with features of raised ICP. And CSF cytology will obviously matter. So yes, in this particular case, because the CSF sugar is normal, this is the reason why the answer to this PYQ would be viral meningitis. But let's look at the third question, which was, I think, a repeat one. And they gave an image. This was last time where a cobweb coagulum could be seen. And in this case, you can see that even in the CSF of the patient, the finding given was that of low sugar. sugar and a grossly increased protein. The moment you are gonna get this low sugar, grossly increased protein, the protein is gonna hang in the test tube like a basketball net at the bottom. So this is gonna be a feature of tubercular meningitis, definitely on. I mean, as far as the third one is concerned, your answer is perfectly spot on, and you need to give 82 to these patients with steroids. Why we give steroids is to increase the penetration of antitubercular drugs, reduce the vasogenic cerebral edema developing in this patient. And more importantly, the point will be, I mean, why do we give steroids here is because the consistency of pus and tubercular meningitis is very, very thick. So if you want to minimize the consistency of pus, we will have to give, steroids to these patients. The fourth question, which I'm getting very, very good answers, is the key word albuminocytological dissociation occurring in a patient. So the correct answer for this one would be Guillain-Barré syndrome, and this is where we'll have seventh nerve palsy and intravenous immunoglobulins would be used in this patient. Yes, Campylobacter jejuni is one of the common organisms which is involved in this case. The most common cranial nerve involved in patients of Guillain-Barré syndrome would be the seventh nerve. We are usually going to get a facial diplegia in the patient. So the fourth one is pretty straightforward one and an easy one. My request to you guys is that the table of CSF analysis is recommended to be remembered. And pyogenic meningitis, pretty straightforward. He'll talk about neutrophils. Then he's going to talk about CSF sugar, which can be 0. And another point that I would like to tell you is that always look at the blood sugar value if given in a question, because normal CSF sugar is 2/3 of the blood sugar. So if you have a grossly decreased values, that's when you say that, okay, there is hypoglycorachia. Hypoglycorachia is the technical term for a low CSF sugar. So always ensure, multiply that by 0.3, 0.66 or 2/3 of the blood sugar, as I mentioned. That's when CSF sugar would be relatively lesser. So the correct answer for this one is GBS anyway. And let's move on to the subsequent one. Here I have there are differentials for albuminocytological dissociation also, that is like Freund syndrome, which could be due to tumors. Moving to the next one, we have a child from a village who's brought with fever and altered sensorium for 1 day. So again, short history is present. But in this particular case, you can notice that the CSF study of the patient is normal. There is the pallor and the ABG shows metabolic acidosis in the patient. So in this case, you can straight away rule out two options, viral meningitis and pyogenic meningitis, because there is a concomitant anemia present in a patient. There is a metabolic acidosis, which tells us that there is a circulatory failure. So I need to take into consideration the remaining two options. Diabetic ketoacidosis does not have anemia. Diabetic ketoacidosis does not have, it will have, I mean, it can produce a metabolic acidosis, but then at the same time, the anemia part cannot be explained. So the correct answer for this one would be given as cerebral malaria. The main objective of the first 4 questions for today is CSF analytic findings have been asked in the exam. In last year's exam, it was Cobb-Webb coagulum. So since, I mean, these are the values. Yes, Dr. Brinda, the sugar value is not given in this particular question, but I think you should always check out the blood sugar value whenever is given, and 2/3 of the blood sugar or lesser should be remembered. Moving to the next question. No, Jerry, I don't think so. But anyway, the database is common. ABG analysis of a patient is showing acidosis because pH is less. Then I'm checking PCO2. PCO2 is less, so it cannot be a respiratory problem, but bicarbonate is less in the patient. So one thing is very, very clear, that the diagnosis of this particular case, the primary change that is occurring in this case would be given as metabolic acidosis. Now you need to apply the Winter's formula. Once you will apply the Winter's formula in the patient, you have to select from the 2 options at the bottom, guys. You need to answer me either one or you need to answer me 2. And whenever there is a metabolic acidosis, you need to then subsequently deploy the Winter's formula to check for the compensation in the patient. So let's do a quick mathematics here. This would be 1.5 into 10 plus 8 plus minus 2. Or a easier way, which I personally feel is easier to remember, is that the modified Winter's formula can also be used in this case, that is bicarbonate plus 15. So when you add 10 to 15, the mathematical value of the expected PCO2 of the patient, this value that I'm writing before you at the moment, is that of a expected. This is a repeat question of NEET PG. The expected PCO2 of the patient is 25, but look at the actual value. If you look at the actual value in the MCQ is 30, which means it is higher, and that means compensation is not going to be answered in this case. Please understand, in all cases of metabolic acidosis, agreed that there is a compensation. वो check कैसे करते हैं? Whether compensation is there or not, you need to apply this formula. if the value of PCO2, if the value of the PCO2 matches with this mathematical output of the formula, then you will say it is compensated. I repeat once again, the basic point to be remembered is if the value, that is the actual value given in the question, is going to match with this particular range, the value is going to be in the mathematical value or the expected PCO2, if both of them will match, you will say it is a compensated disorder. But in this particular case, you can see that the actual value is turning out to be much higher, which means it is a mixed disorder. The correct answer for this one would be metabolic acidosis with respiratory acidosis. The learning point is, I mean, metabolic acidosis questions are the ones which are usually going to be given to you. I mean, that's because that's a very common scenario, and all you need to do is deploy this mathematical range. And if the mathematical value that you calculate matches with that of the actual value given in the question, cool, I mean, that is a compensatory change. If not, it is a mixed disorder. So it's a metabolic acidosis with a respiratory acidosis in this case. Suppose in this MCQ, I'm just saying hypothetically speaking, suppose in this MCQ, this value of 30 was not there, this was 25, then the answer would have been given as 2, metabolic acidosis with respiratory alkalosis. So we sorted for the fifth one. Let's move on to the sixth one for today. This is a case of aspirin poisoning. Now, again, I have deliberately given a similar value so that you can understand this better. There is a acidosis. Can this acidosis be explained by PCO2 value of 30? No, because for respiratory, PCO2 should be elevated, so it cannot be a respiratory acidosis. But there is a low bicarbonate in a patient. So first and foremost, you need to remember that this particular chap is having a metabolic acidosis, and then you will deploy the same mathematical formula, which is that the expected PCO2 of the patient. How do you calculate the expected PCO2? Either you can go the classical Winter formula or the modified Winter formula. That would be 15 plus 15. That is the value given in the question. So what you was noticing for this particular question is that the expected value is matching with the actual value. This means the fact that the compensation part is working, and therefore the answer for this would be that there is a primary change of metabolic acidosis, and along with that there is a compensatory respiratory alkalosis developing in a patient. Another way to crack this question would be ASA poisoning. I mean, if I say salicylic acid, then acid will cause metabolic acidosis, and at the same time, it will stimulate the respiratory center and it will cause a respiratory alkalosis. So I think this question is relatively easier for you to comprehend in the light of the previous one. So the only trick that they did in the previous exam was that the values were not matching, which is why it was a mixed disorder. But then subsequently, I mean, the one that I mentioned is a very classical one and should be easily identifiable. When do I say respiratory acidosis? Then I'll say only when the PCO2 of the patient is elevated. So we are sorted with the 5 and 6. Let's move on to the seventh one. This talks about a CKD patient with vomiting, and the ABG report is given. And when I'm looking at, if the PCO2 value is lesser, then doctor, that means that compensation is working. But if it is higher, that means the compensation is inadequate. So if it is gonna be equal or lesser, it is okay. That's why I said the range. No, I said the range. I mean, the range is ±2. So he says CKD patient with vomiting. What will be the ABG report in a patient? First of all, I mean, I'll try to solve the question in my mind from theory perspective that chronic kidney disease causes the high anion gap metabolic acidosis, and vomiting always causes a metabolic alkalosis. Now the problem in this question is pH at the moment is normal, PCO2 is normal, and bicarbonate is also normal. Normal bicarbonate values are between 22 to 26 millicolaids. So everything is normal. My first report will be everything is fine. But then I'm gonna calculate in this case the anion gap, and for anion gap I'll be selecting sodium, and from this I'll be subtracting the value of chloride and bicarbonate. As I've explained to you multiple times, you are not supposed to include potassium in the calculation. And if you look at the calculation in this case, the anion gap of the patient is grossly elevated. This elevated anion gap is telling you that this value is falsely normal. I repeat once again, the initial impression of mine was that the ABG report is normal. So, I mean, there is nothing to worry. But ABG report in a patient can be falsely normal. The reason for that falsely normal is, I mean, how am I knowing that this is falsely normal? That is on the basis of the value of the anion gap. Now, once you have calculated the anion gap in a patient, then you need to work out what is the problem of this patient. I'll tell you two ways to crack this question. First way will be simple English interpretation. that any patient who's having CKD is bound to have a high in N-gap metabolic acidosis. I mean, every time you read about parenchymal diseases of the kidney, vascular diseases of the kidney, it's a high in N-gap metabolic acidosis. If it is going to be a case of tubular disorders, then it is normal in N-gap metabolic acidosis. So CKD is a high in N-gap, and vomiting will result in metabolic alkalosis in a patient. That is the final answer. But now I will give you the mathematical version. The mathematical version for this would be to calculate the delta ratio. Delta ratio basically means change in the anion gap of the patient versus the change in the value of the bicarbonate of the patient. So the upper limit of anion gap is 12. The actual anion gap that I've calculated is 27. So I will be in the numerator subtracting from 27, 12. That's the upper limit of anion gap normal. And then the average value of bicarbonate we can take is 24. And if I subtract from it, the mathematical value that will work out in this case is grossly high, that is 15. And what you should be knowing subsequently is that we have what is called as a delta ratio. And with help of this delta ratio, we are able to determine whether it is going to be a metabolic acidosis with the metabolic alkalosis. I mean, if you want to get into the mathematics of this question, great. Otherwise, don't bother about it. I have solved the question even clinically before you. The mathematical solution for this is, I'll say once again, point number 1 to be understood in this question is ABG is falsely normal. The reason for that is increase in N gap. Point number 2 to be understood is every time you have calculated increase in N gap, you are supposed to calculate delta ratio. In the exam, you would not have too much of time to get into all these mathematics. So just let it go. And yeah, I'm coming to that partial and decompensated, uncompensated compensation in the subsequent 2 MCQs. But this is gonna be a mathematical justification. Just trying to give a justification for this is what the textbook says, that if the delta ratio is more than 2, then it is a combination of metabolic and metabolic acidosis. Doctor, the thumb technique does not work for this particular question because the values are normal. Let's move on to the subsequent one. And this would help a lot of guys taking care of the issue that the pH of the patient is less and the PCO2 of the patient is elevated. So this is going to be a respiratory etiology, and the bicarbonate of this patient is normal. Now, since a couple of people just requested for this, how to answer the logical question here. So I will spend about 30 seconds more into giving you interpretation. And the interpretation is very simple and straightforward, that every time you have increase of carbon dioxide, you have protons in the body. If you have protons in the body, then body should try to compensate by increasing the value of bicarbonate. But in this question, bicarbonate is not elevated. So the correct answer for this particular scenario will be UC here means uncompensated respiratory acidosis. Why I'm saying uncompensated is because of the fact that bicarbonate value in this patient has not increased. So the subsequent question that I'll discuss with you, you will notice that the values will almost be the same, but at the same time, the values of bicarbonate will be elevated. So yes, Dr. Ria, you perfectly correct in this one. Uncompensated respiratory acidosis. Why? Because bicarbonate अभी बढ़ना शुरू नहीं हुआ है. अगर ये बढ़ना शुरू हो जाता तो फिर मैं बोलता कि ये partially compensated है. Now let's look at this question again. Like he has described a patient of asthma. Then there is a nebulization with salbutamol. Yes, COPD is a good clue. Severe asthma again will cause deterioration. So again the same thing, respiratory acidosis, and in this case bicarbonate is rising. Plus here also the mathematical rule is that for every 10-point increase in the value of carbon dioxide, for every 10-point rise in the value of carbon dioxide, the bicarbonate should be rising by 1 milliequivalent. So you can take an average value of PCO2 of 40. So there's an increase from 40 to 60. That means a 20-point increase. For this 20-point increase, the bicarbonate of this patient is increasing from 26 to 28. So this tells me that the person is suffering from PC, that is partially compensated respiratory acidosis. So, I mean, if you compare the two questions, I mean, the values are deliberately kept same. The only difference is uncompensated because bicarbonate value is normal. And if it is going to be increase in the value of bicarbonate, it will turn out to be a partially compensated respiratory acidosis. Great. And that's because, I mean, why partially compensated? Because person is receiving treatment as well. So great. We are sorted with the 9th one as well. In first 4 questions, I've handled CSF analysis from 4 to 9. I've tried to solve those ABG once again. ओके जी, फिर से बताना पड़ेगा। तो चलो एक बार मैं फिर से ट्राई करता हूँ। बेसिकली कंसेप्ट यार ये होता है, मैं आई ट्राई टू स्पीक दिस इन हिंदी, कि कार्बन डाइऑक्साइड जब बढ़ता है ना तो प्रोटॉन्स भी बढ़ रहे हैं, तो प्रोटॉन्स को न्यूट्रलाइज करने के लिए बाइकार्बोनेट चाहिए। तो अगर बाइकार्बोनेट अभी बढ़ना शुरू नहीं हुआ है तो मतलब कॉम्पेंसेशन स्टार्ट नहीं हुई है, तो उसे बोलते हैं अनकॉम्पेंसेटेड। पर अगर वो बढ़ना शुरू हो गया तो उसे बोलते हैं पार्शियली कॉम्पेंसेटेड। तो अब अगले सवाल में देखो, वैल्यू 26 की 28 हो गई है। फिर मैथमेटिकल रूल लगाना होता है। Mathematical rule for acute compensation is 10:1 का rule. 10:1 का rule means for every 10 point increase in carbon dioxide, bicarb value should increase by 1 milliequivalent. And मतलब यहाँ पे kidney will help in nebulization part. So I mean, if they give clinical clues, that is great. But then delta ratio is doctor change in the anion gap divided by the change in the bicarbonate value. Ag by change in anion gap, and whatever you have calculated, no, from that subtract the upper limit of the anion gap and take an average value of bicarbonate, subtract the actual value of the whatever bicarbonate is given in the question, and you have to generate. I mean, if the mathematical value is less than 0.4, it is a plain NAGMA, normal anion gap metabolic acidosis, grossly elevated, then it would be metabolic alkalosis. Doctor, if your internet connection is slow, you need to change the resolution settings, because in YouTube nowadays there is a setting of auto, so it changes the video resolution automatically based on your video speed. Okay. Okay, we are sorted for ninth one. Let's move on to the 10th one. We have a patient with severe COVID-19. We know COVID-19 patients can land up in ARDS as well. Person will be breathing very hard. So there is bound to be problems of carbon dioxide washout. And that is what is precisely happening in this question. So what you are noticing in this chap is that pH is elevated, obviously, and PCO2 is less. Arrows are going in opposite direction. And since it is a respiratory case, so this would anyway be a respiratory scenario occurring in a person. And because carbon dioxide washout is there, then there would be a respiratory alkalosis present in this case. Now, once you get through this respiratory alkalosis part, please mention subsequently regarding what would you say. Would you like to answer? I give you two options. Is it uncompensated or is it partially compensated? Quickly, guys. Is it uncompensated? This particular case, that's okay. I mean, severe COVID है तो respiratory alkalosis ही होगा ना. Is it uncompensated, UC, or is it partially compensated? ओके, यस, इट इज पीसी, इट इज पार्शियली कॉम्पेंसेटेड। व्हाई? बिकॉज बाइकार्बोनेट नॉर्मल नहीं है, कार्बन डाइऑक्साइड कम हो गया तो बाइकार्बोनेट की वैल्यू भी कम होनी शुरू हो जाती है। यहाँ पे रूल होता है 10:2 का, कि अगर कार्बन डाइऑक्साइड जो है यहाँ पे 10 पॉइंट डिक्रीज होती है तो जो बाइकार्बोनेट होता है वो 2 पॉइंट डिक्रीज होना शुरू हो जाता है, तो 22 की जगह वो 20 के आसपास में हो गया। रेस्पिरेटरी अल्कोलोसिस जो एक्यूट कॉम्पेंसेशन होती है, दैट इज 10:2 का रूल, एंड फॉर एक्यूट इज 10:1 का रूल। मैंने तीन रूल्स बताए हैं। एक तो विंटर्स फार्मूला बताया आपको मेटाबॉलिक एसिडोसिस के कॉम्पेंसेशन के लिए। एटलीस्ट तीन तो याद करो ना। पीपल आर सेइंग सर कॉम्पेंसेशन का रूल सिंपल है यार, एक विंटर्स फार्मूला याद करना है। 1.5 इंटू बाइकार्बोनेट की वैल्यू प्लस 8 प्लस -2, या मैं तो और भी इजी कर दिया यार, कि यू जस्ट नीड टू ऐड 15 टू द वैल्यू ऑफ आई मीन वट एवर इज द बाइकार्बोनेट वैल्यू गिवन, उससे एक्सपेक्टेड पीसीओ2 निकलेगा। देन इज गोना बी 10:1 का रूल, 10:2 का रूल, एंड यू आर एटलीस्ट सॉर्टेड विद थ्री ऑफ देम। So this would be PC. This is partially compensated respiratory alkalosis in a patient. Okay, doc. The bottom line is okay, fine, guys. One is Winter's formula. For Winter's formula in the compensation, what you need to do is the expected PCO to the patient. The PDF डाल दूंगा यार, though I don't know whether PDF will be useful, but I mean it. The point is Winter's formula, expected PCO2 is bicarb plus 15. This is for metabolic acidosis. For respiratory acidosis, if carbon dioxide increases by 10, then bicarbonate value should rise by 1. For respiratory alkalosis in a patient, acute one that I'm talking about, if carbon dioxide decreases by 10 points, the bicarbonate value should decrease by 2 points. And the learning point for you guys is if bicarbonate value is normal with respect to respiratory acidosis or alkalosis, then you are simply going to say that this is the uncompensated value. If pH is totally normal, we say fully compensated. So yeah, it's unlikely that he'll give you a normal pH. No, फिर पूछेगा क्या? I mean, what is he gonna ask you if he's gonna give you a normal pH? PDF will be available, doctor. Yeah, and the video will also be available. Okay, ji. Moving on to the next one, gastric outlet obstruction due to gastric adenocarcinoma. This is gonna cause chronic vomiting in a patient. Every time there is a vomiting, there would be metabolic alkalosis. That is a chloride responsive metabolic alkalosis always occurs in these patients. And while I'm writing this, I have given you substantial amount of opportunity to do the mathematical calculation here also. pH is elevated, PCO2 is elevated, bicarbonate is also elevated. All arrows are increased in same direction. So this would be a case of metabolic alkalosis. And in this particular case, again, we have to calculate, I mean, how do you know that there is a compensation working in this case? Again, you can just simply remember this rule that whatever is the bicarbonate value given in the question, to that you can add 15 and you will work out the expected PCO2 of the patient. Now you are noticing that in this particular question, the actual PCO2 and the expected PCO2 are matching, which means compensation is working in this case. So for metabolic, that's the fourth rule. No, for four disorder to है ना, तो चारों के rules I have told you. Rule to be followed for respiratory acidosis, acute compensation. Rule to be followed for 10:1. Rule to be followed for respiratory alkalosis, acute compensation 10:2. For metabolic acidosis and alkalosis, just remember bicarbonate plus 15, which means that even in this case, there is a compensation process working. That is why I'm saying that this would be a patient who's having partially compensated respiratory acidosis, and this would be a chloride responsive one. So we are sorted with the 11th one. Let's do another one. Calculate the soda bicarbonate correction to be given in a 60 kg patient in a case of uremia. While I'm waiting for mathematical answers, let me calculate the anion gap in this case. I'm going to be subtracting the value of bicarbonate and chloride from this one. This would be 20. So that's an increase one. I mean, the anion gap for the patient is elevated. And anyway, because he's a uremia patients are bound to have a high anion gap metabolic acidosis. Now what you will do is, though there are a lot of controversies related to it, but I'll try to come to the most accurate formula that you need to remember for this one. What you need to multiply the weight of the patient by 0.5, and the average value bicarbonate to be taken is 24 minus the actual value. So if you multiply this here, he's a 60 kg patient, so 60 into 0.5, and then from 24 I'll be subtracting 10. That would be a bit of mathematics for me. That would be 420 milliequivalents, and we don't give whole of it simultaneously. I mean, we'll give half of this initially, and the half of this will be given subsequently. I mean, half of this will be given over 8 hours and the remaining over 16 hours, just like we give with respect to a patient who is having I mean, like in burns, no, you don't give all the fluid simultaneously. Similarly, even in I mean, soda bicarbonate correction, you have to be conservative. Do not do over correction. He says if you will do over correction in a patient, there will be tetany in a patient. You know, na, metabolic alkalosis triggers development of tetany. So over correction is as dangerous because tetany causes laryngospasm. So the point is, over correction of metabolic acidosis is equally as dangerous as metabolic acidosis itself. And in this case, yep, I mean, I'm having a big problem. All arrows are going in same direction, so it's a metabolic acidosis occurring in the person. And yep, I mean, in this case, the guy is hyperventilating, which can explain the low PCO2 values. The correct answer is what I have mentioned before you for calculating the soda bicarbonate correction in a patient. Let's move on to the next one. A repeat from last time's case. A cytic tap patient is showing 600 neutrophils in a patient. I mean, a cytic tap of a patient is showing 600 neutrophils in a patient with CLD patient presenting with abdominal pain. So the point is, I mean, there was an image also given in the exam of a person with gross abdominal distension, and he was having 600 neutrophils. So the clinical diagnosis of the patient would be spontaneous bacterial peritonitis or SBP. Yep. I've zoomed out, doctor. Yep. So the clinical diagnosis of this patient would be spontaneous bacterial peritonitis. Can you quickly comment regarding what antibiotic would be started in this case? Chloride responsive is where we give normal saline. Chloride non-responsive is where we give diuretics. जैसे कि if somebody is having Conn syndrome, so Conn syndrome is a chloride non-responsive one. If somebody is having ascites and is having metabolic alkalosis, we don't give for ascites we give spironolactone. So chloride responsive means where you give normal saline, and chloride non-responsive is where you give diuretics, because metabolic alkalosis is subdivided into two. Vomiting वाले जितने भी case होंगे, they are all gonna be chloride responsive, whereas endocrine problems, ascites, congestive heart failure, they're all examples of chloride non-responsive ones. Yes, we'll give third generation cephalosporins in this patient. So, I mean, this guy is having high probability of going into septic shock. So, ceftriaxone in these patients would be started. Otherwise, in all of these patients, septic shock can develop and person can expire. Plus, there is a high probability of he going into hepatorenal syndrome as well. So, question for you guys: what is first line management for septic shock? What is first line management? Very good. Ceftriaxone. Yep, cefotaxime can be given. If we don't treat this chap, there can be two problems. One, he can go into hepatorenal syndrome, or he can go into septic shock. Question is, what is the first line management for management of septic shock in a patient? Okay, I think I should give options then, right? Absolutely, absolutely. First line management would be IV fluids in the patient. And if he says what is the treatment of choice, then your answer would be norepinephrine. So in septic shock patient, first we have to give fluid, no, normal saline. And what fluid do you give? Don't answer ringer lactate. First line fluid for septic shock is normal saline. पहले septic shock में you have to fluids are given in all varieties of shock except cardiogenic shock. So I mean cardiogenic shock you'll give fluid the chap will deteriorate because heart is not functioning. Understandable. So in septic shock it's gonna be normal saline and then norepinephrine is the preferred vasopressor which is to be used. And very good, very good. I've had correct answers. Quick answers for hepatorenal syndrome type 1, which is a complication here. What would you use for management of hepatorenal syndrome? Somebody mentioned in the chat, so clearly I missed that. So yes, guys, quickly. Hepatorenal syndrome, what would you do? What would you do? Okay, I'm having vasopressin, octreotide, yes. So first we need to get the fluid. You know, there is a redistribution of fluid in the patient. So we can give albumin to the patient. Along with albumin, we can be using octreotide. Yes, very good. So mainly it is albumin, octreotide, or we can be using midodrine as well. That's perfectly fine. I mean, one of the drugs that we use here is midodrine as well. But we need to reduce the underperfusion of the kidney because of the third spacing that is occurring in these patients. So definitive treatment is obviously a had liver transplantation being done in this chap, this situation like this would have not occurred. Okay, great. So we are satisfied with the answers in this case. I'm satisfied with the answers in this one. And the next question, I mentioned the table also. Ascitic fluid of the ascitic tap of the patient was done. And ascitic fluid protein is less than 2.5, SAG is more than 1.1. Serum albumin ascites gradient. If SAG is more than 1.1, it indicates transudative nature. It indicates portal hypertension in a patient. The main point is SAG more than 1.1 is a feature of portal hypertension. That's the first point that you need to remember, even if you don't have access to the table per se. Second, because ascitic protein is lesser, that means liver is not producing. I mean, liver is at fault here. So the correct answer for this one would be a liver cirrhosis in a patient. And if it is going to be nephrotic syndrome, then for nephrotic syndrome, the SAG value will be less than 1.1. So two questions I mentioned with respect to ascitic fluid analysis, like the first four questions were on CSF analysis. Two questions I mentioned for ascitic fluid per se. I'll just go back to that. If they give you a situation of a ascitic patient who's having abdominal pain, having fever, a sudden increase in the ascites. He was having ascites, now it's got converted into tense ascites. And tenderness, if present, it all points towards spontaneous bacterial peritonitis. The count for diagnosis of spontaneous bacterial peritonitis should be more than 250 cells per cubic millimeter. Sir, they don't ask you the dosages, so please don't worry about it at the moment. I mean, let's not focus on the dosages or drugs at the moment, right? It is 250 cells per cubic millimeter as the cutoff. Here it was given as 600, and the second one is going to be for differentiating between the portal hypertension variety versus SAG value more than 1.1 versus less than 1.1. Okay, guys. Sorted for this one. We move on to the next question for which was again a last time's exam question. There is a sudden onset breathlessness in a known case of hypertension. There is a yes, Dr. Zen mode. You have a point. Even nephrotic has transudation, but nephrotic is the only example which is not fitting into SAG less than 1.1. I mean, why we have created that SAG is because the transudative exudative thing does not hold for ascites. Okay, great. Sudden onset breathlessness in a patient of hypertension with elevated PCWP. So what does elevated PCWP tell you? Left ventricular failure. Every time you read elevated left ventricular failure, elevated PCWP, it is indicating that this patient of hypertension is going into left ventricular failure. And even in the X-ray, the heart looks relatively bigger. Plus, you can see a lot of pulmonary edema component. It's not a very classical bat wing. It's not a very classical bat wing, but still, I can say the whiteness is present in the chest X-ray. Bilateral infiltrates are present. So for this patient, we'll have to give nitrates. In the exam, Lasix and furosemide was not given. It was not, Lasix, morphine, then oxygen and positioning were not given. You have to select for N, that is nitrates in the last time's paper. But the main message is hypertensive crisis can trigger development of left ventricular failure in a person. And yep, a bat wing can be picked up, slight bat wing appearance, at least on one side can be picked up. Exactly. Let's move on to the 16th one. The question said elevated JVP finding in a patient with irregularly irregular pulse. Irregularly irregular pulse is what we read with the tachyarrhythmia, that is atrial fibrillation. And because of atrial fibrillation, there would be an absent A wave in a patient. So very good. I think JVP is something that you guys are very strong at. And that is why I'm getting perfect answers in the current from the current group. Great. Very good. Very good. Cool. I'm not able to take your names because I need to focus on my slides subsequently. Let's move on to the 17th and the 18th one, and do read the questions carefully. Try to read them simultaneously. The question says JVP finding in a patient with a large AV, and there is absence of pulmonary edema, versus the second one where there is a large AV but there is a presence of cardiogenic pulmonary edema. If there is a cardiogenic pulmonary edema, it means left side of the heart is involved. And if there is absence of pulmonary edema, it implies that there would be a right side of the heart getting involved. So very good. I think most guys have got it spot on. For question number 17, the answer would be given for large AV would be tricuspid stenosis in a patient. Otherwise, it could even be pulmonary artery hypertension. I mean, there are various reasons for pulmonary artery hypertension, but this would be right-sided lesion. On the other hand, if I'm getting a large wave and I'm simultaneously having a cardiogenic pulmonary edema, then one of the common valvular lesions that must be thought of is mitral stenosis. That is one. Additional point I would like to also add in this MCQ is that patients of mitral stenosis can be having left atrial appendage clots. This left atrial appendage clots can go into systemic circulation, and there can be a risk of development of either a stroke or a TIA in a patient. If he will ask you what drug should be given to prevent or minimize the chances of development of stroke, that do not answer the newer agents like rivaroxaban or dabigatran, your answer should be given as warfarin. If it is non-rheumatic atrial fibrillation, because in majority of cases, it's going to be a rheumatic etiology. I'll just repeat what I said. Every time there is a rheumatic etiology of mitral stenosis, you should be giving warfarin to prevent the development of clots. However, if he gives you a scenario of alcoholic having dilated cardiomyopathy, alcoholics can be having atrial fibrillation because of dilated cardiomyopathy. If there is a non-rheumatic atrial fibrillation, and he says, how can you prevent development of stroke in a patient? Then it is the newer molecules which can be used in these patients like rivaroxaban or dabigatran, etc. I mean, those are the molecules which can be answered in this case. So two additional points have been added to 17 and 18. The main point is right side and the left side is anyway tricuspid versus mitral. And for rheumatic, it is always warfarin to prevent. Otherwise, for non-rheumatic, it is dabigatran. Tricuspid regurgitation, Dr. Kartika, I think this was last time's, the previous discussion that I've done on 23rd of, February, or I think, I think it was done in January. I don't remember the date exactly, either December or January 1. Tricuspid regurgitation results in large development of a large CV wave. So, you have a point there, doctor, but I will not get to the very basics of JVP at the moment. TR operates in ventricular systole, and A wave is related to atrial systole. I mean, the query of yours, the simplest, shortest explanation I can give at this current time is A wave is related to atrial systole, and TR does not operate during atrial systole. TR operates in ventricular systole. So during TR, we get is a development of an absent X and a CV wave, as the remaining guys are answering. Great. Let's move on to the next one. I hope, doctor, your query is answered. The next question says there's an ascites patient with inspiratory rise of JVP. Inspiratory rise of JVP means that there is a Kussmaul sign occurring in a patient. Most of the time when we read about Kussmaul sign, we should always think in terms of constrictive pericarditis, and constrictive pericarditis usually can result in ascites and pedal edema in a patient. Right ventricular compliance is first affected. In constrictive, there's a calcification around both sides of the heart, but right ventricle has less muscle, left ventricle has more muscle. So right ventricular compliance is first affected, and therefore we usually get a pedal edema occurring in patients with ascites. The key word in the question, however, is steep X and steep Y, and that anyway helps in confirming that the question is dealing with constrictive pericarditis per se. Whereas if the question was mentioning additional MCQ that I'm just writing here, is steep X and absent Y. I will be testing you on this topic also in the subsequent part of this particular discussion. But a must-know topic, steep X absent Y for cardiac tamponade, where we always have is a non-pulsatile elevated JVP. In all conditions in cardiology, we have is always a pulsatile elevated JVP. But when you read about non-pulsatile elevated JVP, this is the condition which is to be considered. And yep, I think most guys have answered this correctly. Let's move on to the 20th one now. The question says there's a lung cancer patient and is presenting with prominent neck veins. What is the first differential diagnosis? Avantika says, why would this not be a restrictive cardiomyopathy in a patient? Yeah, doctor. I mean, that is a second differential diagnosis which is to be considered. I mean, no cardiologist will ever be able to rule them out by physically examining them. He will require either a cardiac MRI or he will be requiring an endomyocardial biopsy, because if somebody does not want to risk his practice, he will never dare to differentiate the two on clinical grounds. So, yep, doctor, I can say that if person has had a history of pyopericardium, if has had a history of tuberculosis, I'll think in terms of CP, otherwise RCM is definitely on. And I mean, ruling that out would be almost close to impossible on clinical grounds. We need a cardiac MRI or an endomyocardial biopsy for that. Thank you, doc. Coming to the next one, lung cancer patient with prominent neck veins. This indicates there is a superior vena cava syndrome in a patient. And this will contribute to, I mean, respiratory distress in the patient subsequently. Now, I want you to compare Pancoast can contribute to same presentation, but then Pancoast will have Horner syndrome also. Okay, moving to the Pemberton is with thyroid, so this would not be the appropriate answer, Pemberton. And now I am changing the question, and the question said lung cancer patient with prominent neck veins and electrical alternance. So suddenly you are realizing that, okay, I mean, lung cancer patient can have prominent neck veins due to superior vena cava syndrome as well, but electrical alternance is not a feature that you're gonna encounter with a patient who's having superior vena cava syndrome. Electrical alternance straight away tells you that there is a malignant pericardial effusion occurring in this patient. So the answer to question number 21 will change because of one word. In question number 20, because there was no mention of any electrical alternance, we were not thinking about the heart coming into picture. But in the second question, what I'm finding is, zoom in, okay. But in the second one, there is evidence of change in the fluctuation in the voltage of the QRS complexes, which is pretty visible. Beat to beat variation can be seen, small QRS complexes versus relatively bigger ones. So this is because there is a tumor which has metastasized to the heart. This would be most of the time a small cell cancer of the lung, and the chap is having a malignant pericardial effusion. Very good. I think most guys have got it correct. Moving to the next one, this is again repeat from the last time, digoxin toxicity with development of third degree heart block in a patient. There is a severe bradycardia, there is a AV dissociation occurring in a person. So in this person, if he says what is the first line management for any of these cases, then I will answer atropine. However, since this is a repeat question in the exam, atropine was not in the option. He just said, what will you do? So we, for any patient with digoxin toxicity, will be giving digiband, which is the answer in this particular case. But as I've told you, they can change the language of the question as well. If he says initial management, the moment you read a third degree heart block, heart rate is going to be maybe 40 or less than 40. You need to be aggressive and straight away start atropine in the patient. Lidocaine, doctor, will be the answer to the next question. That is the issue that, you know, some guys casually answered, because now see 23. Digoxin toxicity with ventricular bigeminy. The moment I'm going to have normal sinus rhythm, premature ventricular complex, normal sinus rhythm, premature ventricular complexes. You can see I've shown alternatively. This is a broad QRS complex. Then I'm showing a normal sinus rhythm in a patient. So if you have this alternatively present and NSR, then a PVC, NSR, and a PVC, we'll think in terms of patient who's having a ventricular bigeminy, and this is where we'll be giving lignocaine to the patient. And I mean, that would be, somebody mentioned lignocaine earlier, so I hope now it is clear. For the tachyarrhythmia, which is caused by digoxin toxicity, it's lignocaine. For bradycardia, it is atropine to be loaded, and along with that, digiband to be used. Moving to the next one, again a repeat one. Management of a monomorphic ventricular tachycardia with structural heart disease. Yes, guys. Yeah, phenytoin can be used also. If there is a structural heart disease, the drug of choice for ventricular tachycardia would be amiodarone. Amiodarone is also, I mean, it's a broad spectrum antiarrhythmic. It can be used in atrial fibrillation also. I mean, where will you answer amiodarone? Then there are two answers. Amiodarone is going to be the preferred drug for patients of stable VT for chemical cardioversion, and can also be used for chemical cardioversion in atrial fibrillation as well. Okay, great. If the question says absence of structural heart disease, then the answer will change. Then the answer will change over to metoprolol, that is a beta blocker. And if it says crashing patient, that means BP is unrecordable, broad QRS, QT occurring in a patient. There is heart rate of 200, and I mean, there's a possibility he can go into cardiac arrest subsequently. So in those circumstances, I will have to go ahead with, yes, guys, quickly. Yes, I will be going ahead with defibrillation. Should I answer defibrillation or should I answer cardioversion? Should I answer defibrillation? Should I answer cardioversion? Yes, we will give DC shock, but my query is, should I give cardioversion or should I answer defibrillation? Very good. We'll be answering defibrillation in this case. I mean, we should always give non-synchronized DC shock. Defibrillation, somebody put up, Dr. Mulya put up, when would you answer defibrillation? Pulseless VT and ventricular fibrillation. All others, it is cardioversion. This is non-synchronized DC shock, no? So your answer is defibrillation to be done. Exactly, correct. It is a non-synchronized DC shock which is to be followed. Perfect. Moving to the next one, 26 is sorted. Again, a repeat one. Wide QRS complex tachycardia in a patient overdosing on antidepressants. There was a TCA toxicity case given, like he had mentioned, this lady is suffering from depression. She ate an entire strip of medication, and she would be having development of severe metabolic acidosis. The metabolic acidosis, the protons will cause damage to the myocardium. They will cause damage to the excitability, or they will affect the excitability of the myocardial cells, and thereby there is a triggering of ventricular tachycardia in the patient. I mean, ventricular tachycardia can not only be seen due to hypoxia after myocardial infarction, but can be seen due to metabolic acidosis as well. So in this particular case, we need to treat the acidosis component, which is the reason why for this particular case, the answer that I'll be giving would be soda bicarbonate. And this is taught in pharmacology as well. So a quick repetition. Moving to the next one. Most of the time, it would be a polymorphic ventricular tachycardia occurring in a patient. So we need to give soda bicarbonate for this particular chap. Okay. Moving to the next one, cardiac arrest caused by hyperkalemia will be managed by, let's look at what you guys are answering, calcium gluconate. So please tell me, do you want to, suppose there are two problems in a patient, cardiac arrest and hyperkalemia, which will you treat first? If you're answering calcium gluconate, please simply tell me, if patient is having cardiac arrest due to hyperkalemia, what will you treat first? Will you first treat cardiac arrest or will you first treat hyperkalemia? I am still getting insulin as an answer. Patiromer, insulin plus glucose. Yeah, Torsedis is magnesium sulfate. You will treat cardiac arrest first. So how do you treat cardiac arrest? How do you treat cardiac arrest? Do you treat cardiac arrest with calcium gluconate and insulin? That can be given later. Now, first you will treat cardiac arrest. So what will be your answer? Your answer will be simple: adrenaline for the patient. Yes, guys, the objective was just to tell you that every time they give you a question of hyperkalemia, that does not mean that you have to first treat hyperkalemia. If a guy is gone into cardiac arrest, first give epinephrine to the patient. Plus, give obviously CPR to be given in the patient. The point is, if somebody is having hyperkalemia so dangerous that he went into cardiac arrest, because potassium will slow the heart and can cause a cardiac arrest, then I will give adrenaline to the patient. Cardiac arrest is to be treated on a first priority. Okay, guys. हाँ सीपीआर तो करेंगे ना, मतलब ड्रग ट्रीटमेंट पूछ रहा हूँ ना यार, तो एड्रेलिन देना होता है, sympathomimetic stimulation. Okay, and can be melanophile. You're perfectly right. Adrenaline is a sympathomimetic and will help in entry of potassium into the cells, and that was the concept of the last time's question paper. Okay, जी, great. Sir, norepinephrine तो नहीं देंगे ना यहाँ पे. We'll give adrenaline for this guy. Okay. Moving to the next one, least chances of development of endocarditis would be seen with. The hint is it's a congenital heart disease. It's very common in children with Down syndrome as well. MA says if potassium is more than 6, but there is no cardiac. I think, Doctor MA, you mean that there are no ECG changes, but we still have to give calcium gluconate to the patient. because ECG is not very sensitive. The concept behind that question, I'll repeat, Dr. MA said, if potassium is more than 6 or 7, whatever, and there is no ECG findings, because ECG is not very, very accurate for detection of hyperkalemia based findings. So we still have to take the lab report more. I mean, lab report is more indicative of electrolyte imbalance than ECG. I repeat again, which is more accurate for diagnosis of electrolyte imbalance. Blood report. It is not a ECG. Okay, diastolic arrest will occur, Dr. Farha. That was a good point. And diastolic arrest again will require, I mean, our cardiac arrest will anyway require adrenaline. Yes, guys, I've had correct answer. Least chances are gonna be seen with atrial septal defect. They had given 3 options where there was the requirement of, I mean, prophylaxis for dental extraction before, since a person is having a cardiac issue and was scheduled for a dental extraction, we need a prophylaxis with antibiotics. But AST per se, you don't need any prophylaxis as well. Least chances of infective endocarditis. Then is which will have highest chances of infective endocarditis. The main logic for solving this question is that pressure gradient is directly related. Pressure gradient in the heart is directly related to the development of infective endocarditis. I've ruled out the options. I mean, I've not given you the options of the right side of the heart, so it's only the left sided that have to be taken into consideration. Mitral regurgitation and aortic regurgitation. Let's look at what you guys have to say. Very good. It would be mitral regurgitation because this operates at a higher pressure gradient. I mean, aortic regurgitation will operate at the following pressure: LV pressure. Aortic, it will operate at the following pressure: aorta minus LV pressure. In aortic regurgitation, aorta blood will come into left ventricle. Aorta pressure is 120, left ventricle pressure is also 120. So mathematically, the gradient is not very high. But look at the huge amount of pressure gradient between LV versus LA, which is why mitral regurgitation would be answer to this one. So mitral regurgitation has the highest. I mean, yes, Dr. Amulya, you're right there. Answer 30 is MR and 29 is AST. Moving to 31st, he says, what is best for management of this patient who's a diabetic? He's having low BP, random blood sugar of 600. And I mean, which of the following interventions? These are the 3 options here: plain IV fluids plus insulin, or an insulin drip. In most diabetics, because they would be vomiting also, because ketonemia, I mean, the first differential diagnosis is diabetic ketoacidosis. And in this chap, there would be ketonemia causing a development of vomiting as well. So I need to get the BP back to normal. So I will give fluids plus I'll give insulin to the patient. Yes, it would be IV fluid plus insulin that would be required. Yep. A related question here: electrolyte imbalance that can be seen in a DKA patient with extensive vomiting and prostration. Like this child of type 1 diabetes mellitus missed his insulin shots because there was a marriage in the family. He was using an insulin pump and the parents forgot to recharge or put the cartridge in the insulin pump. This type 1 diabetes mellitus patient missed insulin shots. Then the child has started becoming lethargy, and because mother was busy in the wedding or family members were busy, so they missed that. And then they are noticing that he started having abdominal pain. The child started having vomiting, and he was not opening his eyes and is brought in an unconscious state to your hospital. I mean, the acute abdomen in this condition can be misdiagnosed as even acute appendicitis. So considering the vomiting component, hypokalemia is to be considered in the patient, which is why before you start insulin, you must check potassium. Always hold insulin. The learning from this one is you have to hold insulin if potassium value is less than 3. And you need to first give potassium chloride to the patient. Sir, acidosis causes hyperkalemia. Acidosis will cause hyperkalemia, I agree. But because the person is having extensive vomiting, prostration, in any person who's not eating anything and is vomiting, there is bound to be dehydration. And because of the dehydration component occurring in this patient, I mean, abdominal pain, vomiting, prostration, inability to take orally will cause dehydration. And dehydration always causes stimulation of production of aldosterone. And this aldosterone will cause polyuria, that is urinary loss of potassium. So hypokalemia will occur. So in these patients, if the potassium values are less, I am not going to be comfortable for giving insulin to the patient immediately. 31 is sorted. We come to 32. What is best for diagnosis of rhinocerebral mucormycosis? Yep. What is to be used for diagnosis of this patient? I'm having nasal swab, I'm having an MRI, and I don't think so that there should be any confusion. Why rhinocerebral mucormycosis will involve the sinuses? No, so you can't put a swab in a sinus. Swab will remain in the nose only, na? Maybe the fungus is growing in the maxillary sinus. or is growing in the ethmoidal sinus. So your swab will not go there. No? So you will be doing a MRI, and after doing a MRI in the patient, then subsequently a nasal endoscopy with biopsy will be done. The question is a repeat one of the last time's exam. Please remember, nasal swab is not going to reach the sinuses. You need to do an MRI, and then subsequently, why? I mean, swab no use does not mean that micro tests are not good. By swab no use, it means that the infection is located deep inside a sinus, and you can't navigate a swab in there. So we will have to go for a MRI followed by nasal endoscopy and biopsy. The answer would be MRI. Yep, amphotericin B to be given. Then, though this has been discussed in your microbiology section also, just a quick, recall of the images. If you're gonna get these, I'll use a different pen to highlight, zooming it in slightly. And if you are gonna get a Gomori, the green slide here is Gomori methamine stain. In Gomori methamine stain, if you're getting branching at 45 degrees, let me just try to change the color. If I'm gonna get this branching at 45 degrees or so, this is gonna be aspergillus acute angle, whereas you can see broad aseptate hyphae. Use a different color. But if I'm able to notice this broad aseptate hyphae, then this would be for mucormycosis. And then, I mean, one is acute angle thing, which you are aware of. Second is this aseptate hyphae, which is, I think, already given on the slide somewhere. And then they can give you an image of a person in whom inside the macrophages, you would be having these small lesions present. That would be for histoplasmosis. And if you're going to have a broad-based budding, as is shown in this one, then it would be blastomyces. So, I mean, common infections can anyway be asked in patients who are having diabetes and had COVID. Mucor was anyway there. Aseptate hyphae, broad aseptate hyphae were present. Okay, fine. For aspergilloma, please just quickly comment on the antibiotic of choice, and we can move to the subsequent slide. If a person is having a aspergilloma post-COVID, he was put on steroids, and he's having a aspergilloma in the lung on a CT, what drug would you give? So you'll be giving voriconazole for the patient. Yep. Okay, fine, great. 32 is sorted. We move to 33. The question said, what is the initial treatment for a patient of acromegaly? There is a growth hormone producing pituitary tumor, and I want to cause a shrinkage of the tumor. And you have to tell me the drug that would be recommended subsequently. Yes. Yes, I need to shrink the pituitary tumor. So I'll be using, okay, more accurate answer would be lanreotide in contrast to octreotide, because I want to give a long-acting formulation to reduce the discomfort of the patient, but this would be the initial one that is recommended. But if they start having visual deficits like bitemporal hemianopia, then a transfemoral surgery. No, doctor, it is not pegvisomant. Pegvisomant is only to be used if there is a recurrence of a tumor. It can be used even initially, but in growth hormone producing pituitary tumor, if you want to shrink the tumor, and the advantage of shrinking the tumor will be that lots of time the mass effect of the tumor is present. No? So to shrink the tumor, initially we give octreotide or somatostatin based derivatives to the patient. Okay, we can give subsequently, doctor, we can give cabergoline and bromocriptine to the patient orally, but initially to shrink the tumor, it is because the remaining drugs, they act by increasing the level of dopamine. But to shrink the tumor initially, we have to use octreotide based derivatives. Okay, moving to the next one. The question says AIDS positive patient with features of lobar pneumonia, CD4 count is 200. So here we'll go by the finding of lobar pneumonia. Lobar pneumonia is a presentation that is seen with pneumococcus. And therefore in this patient, I'll be starting antibiotics. The antibiotics that I'll be giving in this patient would be like a respiratory fluoroquinolone, levofloxacin. And along with that, I can give macrolide like azithromycin. Till last year, I would have answered only plain azithromycin for this patient IV. But now, because of multi-drug resistance for pneumococcus, we tend to give respiratory fluoroquinolone. And along with respiratory fluoroquinolone, azithromycin would be given. That's because of indiscriminate usage of macrolides. Resistance is being occurring to both of them as well. The answer to this question is not pneumocystis jirovecii, because there is lobar pneumonia. Suppose in the same question, the language was the same, but he mentioned that the chest X-ray of the patient is normal or is showing occasional infiltrates, some infiltrates, but not lobar pneumonia. then I could have considered a possibility of pneumocystis jirovecii, for which I will have to go in for bronchoalveolar lavage in a patient. This bronchoalveolar lavage will be showing black cysts in a green slide. There will be multiple black cysts that would be visible. And then I'll say, okay, this is going to be pneumocystis jirovecii. So the correct answer for this particular question that I put out before you is pneumococcus. However, if it is going to be normal X-ray infiltrates, BAL, then yeah, doctor, CD4 count can be lesser, but the most common infection will occur in a lower count. So don't go by the count report, no? Don't go by the count report. If there is lobar pneumonia, girovecii does not cause lobar pneumonia. Yes, here it would be cotrimoxazole that would be given. Absolutely. They'll give you a green slide with black cyst. That's why we call it pneumocystis. Okay. And we also give steroids there. The reason for that is when you kill pneumocystis jirovecii, there can be a cytokine storm in a patient that can cause worsening. So we also tend to give steroids in the patient. Ideally, so we should. This will not happen. No, nowadays patients are started on CART. No, we don't wait for the CD4 count to answer the CD4 count to fall, and then we start treatment. I mean, the treatment objective nowadays is to start CART the moment we have diagnosed AIDS in the patient. Doctor, if he says CD4 count less than 50 and he says that there is a lung infection in a patient, then atypical mycobacteria, that is Mycobacterium avium intercellular, is to be considered, where we'll be giving clarithromycin to the patient. Lobar pneumonia is pneumococcus. It's not staphylococcus. Staphylococcus can also cause lobar, but the most common cause of lobar pneumonia is pneumococcus only. Okay, CD4 count is not a criteria for diagnosis. If it is less than 500, tuberculosis less than 200, chances of girovecii, but pneumococcus is more common than girovecii infection. That's one. At 100, cerebral toxoplasmosis incidence increases. At 50 or lesser, there is going to be cytomegalovirus retinitis and Mycobacterium avium intercellular. Yes, it is clinical findings that will decide the treatment. Okay, ECG findings of ST depression are seen with which drug? The answer is digoxin. But then there was a modification in the question. The question said ECG finding of ST depression with prominent U waves. Yes, this would be a hockey stick here. So gross differences in the configuration. The hockey stick one is a feature that we encounter. The hockey stick one is what we encounter with digoxin. And then there is going to be a ST depression, plus there is some magnitude of T wave inversion in a patient, plus there is a prominent U wave also. That would be a feature with hypokalemia. Yep, I mean, extensive use of furosemide can trigger hypokalemia in a patient. Moving to the next one. A road traffic accident patient develops breathlessness after 48 hours and petechial bleeding is noticed in the patient. SPO to the patient when the nurse put the pulse oximeter is 80%. I mean, every time there is going to be a trauma in a patient and then there is going to be breathlessness, you need to deploy GERD's criteria, GURD. GERD's criteria include presence of petechial bleeding as well. So, I mean, we straight away are not going to think in terms of fat embolism, but considering that there is a petechial bleed documented plus respiratory distress, I mean, the major criteria I'll say are lung involvement, brain involvement, and then development of bleed in a patient, petechia. Then these are important features which you must consider for fat embolism syndrome in a patient. The clinical diagnosis in this case is FES. I'll use a short form. By CNS feature, I mean development of coma in the case. Yep. Subsequently, lipiduria can also occur. Okay, moving to 38. I'm having a patient who's having shortness of breath after a long distance flight. So whenever we read about long distance flight and nephrotic syndrome, we are talking about increased chances of clot formation. Nephrotic syndrome by itself is a hypercoagulable state. And considering the fact that we are dealing with a hypercoagulable state in a person with development of respiratory distress, we have to think in terms of pulmonary embolism. The question is saying, what is the test to be done in this case? The answer would be what most guys have answered very correctly. That would be a CTPA in a patient. Yeah, I mean, we have to answer the main test, no? Like if a person is having shortness of breath, so I need to identify what is the cause of shortness of this breath. So I'll be doing a CTPA in the patient and CT pulmonary angiography in this particular case. Yes, it is available subsequently also. The CTPA will be showing a thrombus in the pulmonary artery. Most of the time, I mean, there's a pulmonary artery that would be visualized. You'll be able to see the descending aorta. You'll be able to see the ascending aorta. And you will notice that there is like this contrast defect, filling defect that would be present. The pulmonary artery will be totally white, and then there would be a gray area. Like, let me say, one of the branch of the pulmonary artery is patent, but then there's a cutoff here. That cutoff is because of a clot which is present in the pulmonary artery of the patient. Okay. 38 is sorted. Let's move to the next one. A patient after joint replacement surgery is having shortness of breath on day 2 with prominent neck veins and low BP. Waiting for your diagnosis. Palla sign is a good one for diagnosis. Absolutely true. Yeah, you can have a saddle embolus as well. The complication is deep vein. I mean, this is deep vein thrombosis occurring in a patient. Okay. And okay, I'm missing a couple of points in the chat. Okay. Patient after joint replacement surgery develops shortness of breath on day 2, and there is prominent neck veins occurring in the person. He's asking me for what is gonna be done for this case. Yes, guys. Okay. Okay, let's quickly first work out the problem in this case. Post joint replacement surgery, there is a large vein. There is a clot probably in the popliteal vein or in the femoral vein of this patient, which has gone into the lungs and is causing a massive pulmonary embolism. In any patient of massive pulmonary embolism, the systolic blood pressure, whenever it falls, there is a big clot bang in the middle of a pulmonary artery. You need to destroy it, and the only way you can destroy it by doing a thrombolysis in this case. The main pointer for this question is he gonna be talking about a massive pulmonary embolism, or is he gonna be talking about a submassive pulmonary embolism? Because in submassive, the BP will not be low, it will usually be normal. In this particular question, because low BP is given, that is why the answer to this question would be given as thrombolysis. However, if in this question BP was not getting affected, right ventricle was not getting dilated, then we would have answered this as heparin. We would have given low molecular. Heparin will be given in point number 1 also. In massive pulmonary embolism also we give heparin, but the main treatment for massive pulmonary embolism is going to be thrombolysis to be done, and one of the important parameters will be the low blood pressure of this patient. I mean, that's a good point to identify clinically, though ideally we need to do a CTP and demonstrate a clot. Empirically, I just can't say because BP is low, I'll do a thrombolysis. In an era of evidence-based medicine, I need to demonstrate the presence of clot, so I need to do a CTPA, visualize the clot, and then subsequently do a thrombolysis in the patient. 39 is sorted. We come to 40. I think ऑक्सीजन तो सर देंगे ही देंगे ना. मैंने ऑक्सीजन तो मतलब किसी को भी सांस लेने में, any patient having a difficulty in breathing, you'll be giving oxygen. Okay, shortness of breath after a central line insertion would be seen with thrombolysis would be contraindicated in submassive variety. We give thrombolysis only in the massive variety. Thrombolysis not given. Contraindications thrombo मैं लिख देता हूँ, बाकी I'm waiting for answers for you guys. Contraindications for thrombolysis would be like non-ST elevation MI, so many of them, no, unstable angina, plain pulmonary embolism, not massive one, plain pulmonary embolism. If BP is very, very high, systolic blood pressure going beyond this range, recent hemorrhagic stroke. I mean, any chap who's had a brain hemorrhage, I cannot be taking a risk of doing a thrombolysis in a patient. Aortic dissection. So there are so many of them. And I would not suggest you to go into any kind of a mnemonic for it. Pretty straightforward. These are, I mean, contraindications for thrombolysis. I think I have to glance at the phone for a second to look at shortness of breath. Absolutely correct. There is shortness of breath after a central line insertion. This means that probably the central line has caused damage to the lung. The first answer of yours would be development of pneumothorax in a patient. And suppose if pneumothorax is not given in the options, then can you tell me another differential for why the person will be having breathlessness? Yes, guys. Suppose pneumothorax is not in the options. Yep, large vein thrombosis in any patient, joint replacement surgery, no, the major criteria are being satisfied. Yes, the second differential to be considered in the patient then would be air embolism. Answer to 40, and most of the time there's a chart given in Harrison in which he has mentioned BP values for somebody put up, sir, will we look for Wells criteria? My suggestion is there's a small chart, and I think I've discussed that in the routine section. Look at the BP values. That is a very good hint towards solving the questions of pulmonary embolism of the massive variety. Okay, let's move on to 41. The question says absent air entry and absent breath sounds with deep pulses sign on a chest X-ray is managed with. I've solved the question half for you guys. Absent air entry, absent breath sounds would be a feature that is seen with pneumothorax. Deep sulcus sign is also visualized here. If you compare the costophrenic angles on both the sides. So considering the fact that a person is having a fairly large pneumothorax here, there are absent vascular markings. I will have to manage the patient aggressively. So I'll go in for a needle thoracostomy plus a tube thoracostomy in the patient. Absolutely right. Yep. We'll be going in for needle thoracostomy plus a tube thoracostomy in the patient. Okay. Thoracocentesis would be a wrong statement. No, C में thoracocentesis नहीं करते ना. It's a wide bore needle decompression. Why answer number C is not? Because we're not doing a thoracocentesis. It would be a wide bore needle decompression that we're doing. And for that, we don't need to get into that controversy of fifth versus second intercostal space. He says whatever is available, you can use in the patient. It can be fifth, it can be second. Yes, there's no fluid, it is air present. 41 is sorted, we move to 42. Yep. Hammond-Crunch sign would be seen with respect to Hammond-Crunch sign would be as if somebody is walking on only wide bore needle. Yes, you can select it. Yes. Thoracocentesis. That is why the answer is not gonna be given. The main answer for this patient is the definitive treatment for pneumothorax would be to put in a needle, decompress, and at the same time put in a chest tube. Hammond-Crunch sign would be seen with exactly Boyer syndrome. This can be seen with patients who are having a pneumomediastinum. Pneumo questions are always asked. Pneumothorax, pneumomediastinum are two important questions or topics which are always one pneumo will at least come, either pneumoperitoneum or pneumothorax or pneumomediastinum. Yes, one scenario can be Boyer syndrome. Okay, moving to the next one. Yes, this is where the X-ray finding of continuous diaphragm sign would be seen. Niglerio sign, Sale sign can be seen, but the one that is easy to pick up is continuous diaphragm sign. Moving to 43, forceful retching minus vomiting in an alcoholic patient with excruciating epigastric pain and inability to pass NG tube. Like this is the keyword in this question, inability to pass NG tube. NG tube हमेशा ही जाती है. Only time you can have problem in NG tube is when it's navigating through the oropharynx of the patient. It can trigger a bit of gag, and the person might hold your hand, or the spasm or the gag can actually impede the passage of tube. But once it goes down into the esophagus, there is never a problem. The only time this is gonna be seen is gonna be a case of stomach volvulus. Can you tell me the name of this triad here that is being asked by you? The clinical diagnosis of this guy is the stomach is folded on its axis. It can be a organoaxial or a mesenterico-axial volvulus occurring in a person. Yep. In this particular case, this would be yes. No, this is not Mirizi. Mirizi to gallbladder से related होता है ना? Yes. The clinical diagnosis of this case is stomach volvulus. There is the features are retching minus vomiting. That's the key word. Retching to hai, but there is no vomiting in a patient and a severe epigastric pain developing in a patient. This, sir, macular striate to will be for Boyer-Haave, no? Where you have is a subcutaneous emphysema. This would be a Borchardt striate. Macular is in Boyer-Haave syndrome. Yeah, this would be Borchardt. Absolutely. Abhishek, you perfectly bang spot on. This is not Boyer-Haave syndrome. No, we are talking about stomach volvulus. Yes. Perfectly right. This would be Borchardt triad. Absolutely. The key word in the question is inability to pass NG tube. Normally that does not happen. So the triad has to be remembered. Macular is for a patient who's having Boyer-Haave syndrome. Okay. This is a image with respect to clot present in one of the branches of the pulmonary artery. Actually, the image should have come earlier, but anyway, has been asked in the exam, so one should give consideration to that. Okay. Okay, coming to the next one. Yes, this would be PE. And coming to the next one, this is the one that you guys were saying. Alcoholic with a forceful retching, followed by chest pain and subcutaneous emphysema. I think you can see this subcutaneous emphysema present here. I mean, air below the chest wall, so there would be crepitus here. So either he will write crepitus in the chest wall, or he's gonna write the word subcutaneous emphysema as given in this question. For this one, the clinical diagnosis would be given as Boyrav syndrome. Let's move to the 45th one. The question says, alcoholic with severe epigastric pain radiating to the back. This would be acute pancreatitis. We need to do a CT in this guy to check out the severity of acute pancreatitis. So 3 questions on alcoholics here. And then we'll talk about management of tumor lysis syndrome in a patient. For management of tumor lysis syndrome, yes, acute pancreatitis. Absolutely right. Absolutely right. Next one, I have not put up a question. The queries that I usually get is that for question of acute pancreatitis, should we answer rasburicase? Should we answer allopurinol? Should we answer IV fluids? So let's look at how to answer these questions. And the logic behind this is that the malignancy which is present in the patient will decide. Suppose, what I want you to understand is, first of all, I'm slightly zooming it in. If he's going to talk about a high risk group, like if he begins by describing a child with Burkitt's lymphoma, or he says acute lymphoblastic leukemia child with a high TLC going up to 1 lakh, TLC 1 lakh, that is hyperleukocytosis. I'm not talking about leukocytosis, I'm talking about hyperleukocytosis, TLC 1 lakh in a patient, high risk group, then you should answer rasburicase. But if it's going to be a patient who is, let me say in a low risk tumor or intermediate risk tumor, then we should be answering allopurinol. Once I've told you that you need to look for Burkitt's lymphoma, ALL given in a question, then is this flowchart which is to be remembered. If he says, how do you prevent intermediate risk? It is IV fluids with allopurinol. For high risk, it is IV fluids with rasburicase. If it has already occurred in the patient, if tumor lysis syndrome has already occurred in a patient, then answer will be again rasburicase. I hope I've been able to clear the aspects of tumor lysis syndrome, which we say puke calcium. By puke calcium, puking means that things will become lesser. So let's look at what will become less in this patient. Though it is very clear, P would be potassium will become less in this patient. Puke calcium. So the point is, what will become elevated in this patient? So potassium will become elevated because cells will die. Then U would be uric acid. So uric acid values will again be rising because cells are dying. DNA turnover will contribute to problems in this patient. Plus phosphate will also rise because ATP. But what is going to become less is calcium, because there is going to be binding of phosphate to calcium. So puke calcium, the mnemonic would basically mean that, you are puking calcium in the sense that what is less, calcium is going to be less in this case. So for management of this patient, because you know that there can be crystals of uric acid blocking the tubules of the kidney, and this guy can develop acute tubular necrosis. Whether he's asking you prophylaxis, whether he's saying treatment, first line management is always IV fluids. How to select between allopurinol or rasburicase, as I've explained. If he talks about a Burkitt's lymphoma, ALL with hyperleukocytosis, then answer rasburicase, otherwise answer allopurinol for prophylaxis purposes. If he says what is the treatment, then it is right in front of you. So most of the time, tumor lysis syndrome is again a very common topic that is asked both in medicine as well as in pediatrics, but it is always a controversy with respect to what is to be done first, what is to be done subsequently, and the big fight over what drug is to be answered. So I hope this should yeah, I'll complete all the 100 questions, doctor. Don't worry. Time is not a consideration for me. I'll not tell you that you don't need to listen to me for the remaining ones. So if you are patient and listening to me at the moment, I would request you to be patient for another hour, and I'll finish all of them. I will complete all of them, doctor. Don't worry. It's my job. Don't worry. We are sorted with question number 46. PDF of this would be available in the group if you want to go through. Last minute quick revision, turning through the pages. Don't spend too much of time on that. Okay, guys, moving to the next one. He says, child, again a repeat question, last time, pediatrics/medicine, child with abdominal pain with extensor purpura. So keyword in extensor purpura is always going to be enoxacoline purpura. Plus, there was some kind of an image of a kid with this rash on his back of the thighs and on the calves of the patient. He's asking, it is managed with, right? So your answer is gonna be, guys, diagnosis nahi pucha na. The answer here is steroids would be used. IgA mediated, absolutely, absolutely. It is a IgA mediated disorder. It is IgA1 mediated disorder that causes phenolphthalein purpura, and IgA1 mediated disorder also causes Berger disease. But the difference is in Berger disease, it would be damage to the mesangium, it would be damage to the kidney, and therefore RBC leakage would be occurring in this patient. So there would be a microscopic hematuria on a, I mean, most of the time these patients would be suffering from hematuria on a long-term basis. ऐसा क्यों होता है यार? Just generally asking, though this is not the time for asking you this. Can you tell me why the same antibody is causing in some patients it is HSP, in some patients it is Berger disease? One is child versus adult, that is okay, but why? I mean, ऐसा थोड़ी ना कि बच्चे के body अलग होता है adult का. Physically is fine, but human ही है ना. So, I mean, can you tell me the reason why? Yeah, doctor, there is no thrombocytopenia. This is platelet count is normal in henoch-Cullen purpura. It is IgA mediated damage to the blood vessel wall, so it is also called as non-thrombocytopenic purpura. A good point that I have incorporated here. Why do two different people will develop HSP and the other person will develop Berger's disease? It's mainly due to HLA variability. I mean, HLA genetic makeup of everybody is different now, because HLA of everybody is different. In some people, IgA1 is causing damage to the skin and to the joints and causing damage to the blood vessels of the GI tract. So you get, I mean, three things: abdominal pain due to vasculitis of the GI vessels, vasculitis of the skin blood vessels. So there is a purpura developing, and even vasculitis of the blood supply related to the joint, so joint pain will be seen. But HLA variability in some people ensures that IgA1 attacks only the kidney, and that is when we have a common glomerulonephritis developing in the patient. Yeah, that is Berger. वो तो हो गया, वो तो क्या, you guys are smart enough for that. Moving to the next question, again a last time repeat question. Now the term used is multiple endocrine neoplasia type 3, which is formerly called as MEN2B. And you have a couple of M's here, which are to be remembered, like you have these bumps, bumpy tongue, bumpy lips. So you're gonna say mucosal neuromas present in this particular chap. That is one of the characteristic features in men. Then we have another M coming up, that would be megacolon. We also have mucosal neuromas, megacolon, marfanoid habitus developing in these patients. Another M is medullary thyroid cancer developing. So there are four M's that I've described. I'll say them again: mucosal neuromas, megacolon, marfanoid habitus, and medullary carcinothyroid is what you see with MEN2B. Parathyroid adenoma will obviously be the one which will be the odd one out in this case, which would be a feature of MEN2A, or called as MEN2. Exactly, the answer would be D. Then you should also be knowing regarding genes and chromosomes for each one of them, because I think that you have studied them in other subjects also. Please tell me which chromosome is involved in MEN4. MEN4 is having features of MEN1. Plus, you could be having some special features. While I'm writing those features, question for you guys, without using Google, you have to tell me that which chromosome defect is related to MEN4. Features of MEN1 plus neuroendocrine tumors will be present. These neuroendocrine tumors can be of the cervix. That's the peculiar thing. I mean, the neuroendocrine tumors, or he might just say reproductive tract tumors in a patient. But then where do you read about gonadal tumors? Gonadal tumors are read with MEN4. I'm having exactly very good answers there. The defect would be on chromosome number 12. Just remember three numbers there. That would be 11, 10, and 12. The three numbers to be remembered, I'll say them once again, are numbers to be remembered are: for MEN1, it is menin gene, MENIN, that plays an important role in cellular differentiation, menin1 gene. For MEN2, you read about red proto-oncogene, that would be in chromosome number 10. The number is 11, 10, and 12. Then is menin1, then is red and gene, then is what guys I mentioned, that is CDK, cyclin base, CDKN1B, for patients who are having multiple endocrine neoplasia type 4. The numbers I'll mention one again. The chromosome numbers to be remembered would be 11, 10, and 12. 11 would be for MEN1. This would be for MEN2A and B as well. And this would be for MEN4. Then is menin. Then is gonna be red. And then is cyclin, yeah, cyclin dependent kinase inhibitor 1B gene. So CDKN1B. Okay, great. Reproductive tract tumors are a feature of MEN4. Great. Let's move on. Soda bicarbonate, I've already solved for you. You need to multiply the weight by 0.5 and 24 minus the actual value. For sodium, just remember that don't multiply straight away by 0.5. You first have to take into consideration total body weight of a person, total body water of a person, which will vary according to the gender. For a male, the total body water, which is to be considered, would be multiplication factor of 0.6. And for female, the multiplication factor to be taken will be 0.5. And I mean, what you need to do in the question is whatever is the weight of the patient, you need to multiply that by 0.6, 0.5 into 140 minus actual value for the total correction. This is for the total deficit in the patient. But we will not correct the entire deficit in a single day. You very well know that if we try to do a fast correction in a person, there can be development of central pontine myelinosis in a person called as osmotic demyelination syndrome. So if we will specifically say what is the correction per day, ye dekh lena whether the question is asking you the total deficit or whether it is asking how much will you correct per day. For the correction part, whatever is the value given in the question, suppose sodium value is 120. Then you don't need to increase from 120 to 135 in a single day. You need to increase from 120 to 128, from 128 to 135. It's a gradual rise that I want. I don't want a fast rise because of the risk of osmotic demyelination syndrome, which can cause a stroke-like presentation in a patient. The guy will become crippled for whole of his life. Osmotic demyelination syndrome features develop 24 to 48 hours after correction. They do not develop immediately. Features of osmotic demyelination syndrome develop 24 to 48 hours after fast correction. And what is going to happen in the patient? There is going to be development of quadriplegia because of demyelination of the corticospinal pathway. Plus, over and above this, cranial palsies will start occurring in a person who can't talk, can't eat, can't speak, because cranial palsies with respect to the brainstem would be affected in this patient. So it's always a slow correction. I would also like to clarify, yes, mutism will develop in this patient. I would also like to clarify that if it is an acute onset hyponatremia, then you don't need to go into all this. For acute onset hyponatremia, you can just give a 3% saline fast 100 ml, and this will cause correction in a patient. Let me just clarify this in an additional slide and listen to my point very carefully. Suppose he describes a patient having a acute onset hyponatremia. The sodium value of the patient is about 120. Then we have usually seen that if we increase this to about 125 odd, patient will stop having seizures. Acute onset hyponatremia, if a person is having seizures, you can rise it very fast. What we do in the patient is we give 3% saline. This is available in 100 ml, bags, and this can be given relatively fast to the patient. That slow thing is valid only for chronic hyponatremia. Like for example, I gave a situation also, like an athlete has not athletes, they stop drinking water and stop taking salt for few days before they go for a competition. Now, like, I gave an example of Sushil Kumar and others, he won a gold medal for us, but I said कि competition से 2 दिन पहले यार पानी पीना छोड़ दिया, salt लेना छोड़ दिया. तो जिसमें क्रॉनिक हाइपोनाट्रीमिया होगा ना, क्योंकि बाउट में तो उसका लॉस होना ही होना है. लेकिन अगर वो एथलीट का एक सिनेरियो देता है, एथलीट्स डेलिबरेटली डू वाटर रिस्ट्रिक्शन, सॉल्ट रिस्ट्रिक्शन बिफोर अ कंपटीशन बिकॉज दे हैव टू फिट इनटू अ वेट कैटेगरी. So if it is chronic hyponatremia, definition of chronic is more than 48 hours. Like I said, an athlete has stopped taking water and salt for a few days before competition to fit into a category. Or he gives you a scenario of SIADH, syndrome of inappropriate ADH secretion, which will usually be given. SIADH usually occurs due to a CNS problem. So person might be sick, AIDS positive patient having seizures, cerebral toxoplasmosis. He's admitted with these multiple seizures for last 1 week in your hospital, and somebody having chronic hyponatremia, sodium of 120. Then he says it is a gradual rise. So that formula that I have told you, that formula is valid for the chronic variety of hyponatremia, not for the acute onset. For acute onset, you can do a fast correction and patient will be fine. But like I gave an example of athlete, or I said SIADH patient admitted in a hospital, he will not write SIADH. He will say cerebral toxoplasmosis. Brain abscess patient admitted into neurosurgery unit for an aspiration of a brain abscess. and was having multiple seizures also. And now this particular patient, medicine call came because this child seizures are not responding to the routine antiepileptic drugs, and you check the electrolytes and sodium was less. That's the usual scenario. Brain abscess patient admitted in neurosurgery for aspiration because he was having a focal neurological deficit. Post aspiration, he's having seizure. They put him on phenytoin, etc. Still the seizures are persisting. Medicine call came. We found, okay, 2-3 days admission, chronic hyponatremia in a patient. So just wanted to clarify on that. Let's move to the next one. Hyperventilation, which will lead to which ABG change and which electrolyte change? Two questions here simultaneously. Hyperventilation will contribute to which ABG change and which electrolyte change in a patient? The ABG change in the patient would be respiratory alkalosis. And if it is going to be electrolyte change, then alkalosis always causes redistribution of calcium. So hypocalcemia can be a big time risk. Very good, very good. Moving to the next one, again a repeat from last time. High urine osmolality and low plasma osmolality can be seen in. Every time you read a question in which urine osmolality and plasma osmolality is having an inverse relation, it means the fault is lying with antidiuretic hormone. The basic rule is just like, sodium, potassium go opposite with aldosterone. Similarly, urine osmolality and plasma osmolality go opposite with antidiuretic hormone. So now I need to figure out, is this patient having diabetes insipidus or whether the person is having SIADH? Because he's saying the word low plasma osmolality, it means that there is excess of antidiuretic hormone in the body, because excess of antidiuretic hormone will cause more water in the body, and this water in the body will then cause dilutional aspect coming in. Dilutional would not be an appropriate way to describe it. So the person will be having a euvolemic hyponatremia. The question of the last time's exam said, which electrolyte imbalance is likely to be seen in a patient having high urinary and a low plasma osmolality? Your answer would be hyponatremia. Answer to question number 51 is hyponatremia. Yes, I think everybody got this one correct also. That is SIADH would be present in this patient. Absolutely. Not hypokalemia, because antidiuretic hormone का तो यार potassium पे फर्क नहीं पड़ता ना. It is aldosterone that has an effect on potassium. Great. Euvolemic hyponatremia, SIADH. Usual causes of SIADH will be CNS causes. Cerebral toxoplasmosis in a patient, or brain abscess in a patient, CNS, or it could be encephalitis, meningitis of any etiologies. AIDS positive patient with meningitis, that's where SIDH can occur. Okay, ji, quick look at the following rhythm disorders. The first one, you will notice that there is a irregular rhythm. The RR interval of the patient is changing. RR interval of the patient changes with respect to atrial fibrillation and multifocal atrial tachycardia. In this particular case, there is absent P waves. All I can notice is a bit of twitching. So the rhythm disorder, which is mentioned in this case, should be answered as atrial fibrillation. The chemical cardioversion agent that I can be using in this patient is, mostly in our hospitals, we have availability of amiodarone, or we can use other agents also. I mean, ibutilide, dofilitide are other molecules which can be used as well. Absolutely. Identify the rhythm. The answer is atrial fibrillation. Chemical cardioversion is amiodarone. First line management is beta blockers in this patient. Good. Very good. I'm having good comments here. Lignocaine नहीं देंगे सर. Lignocaine is for VT, right? Okay. Dose वोज पे मत जाया करो सर. सर द मेन कीवर्ड, इसमें द कॉमन एरर इज एट्रल फ्लटर, कि भाई ये जो वेव्स है आपको फ्लटर वेव्स लग रही हैं. तो वहां पे मेरा पॉइंट सिर्फ इतना ही है कि सर फ्लटर वेव्स में तो देयर इज ऑलवेज अ स्टैंडर्ड, आई मीन द रिदम इज नॉट इरेगुलरली इरेगुलर. द कीवर्ड इज इरेगुलरली इरेगुलर रिदम. आई विल जस्ट जॉट इट डाउन. Irregular RR interval. Yeah, if he gives alcohol history, that's okay, but one liner में बहुत बार नहीं भी देता. Then again he says identify the rhythm and mention the chemical cardioversion agent in this particular case. So first I'll be just checking out the RR interval of this guy. I mean, I can count 2 squares versus if I scan a little to the left, I can count 3 squares also. So once again, this particular question is that of a irregular RR interval. But simultaneously, what I can notice is these waves. which are present right before the P wave of the patient. So P waves are present, so it cannot be atrial fibrillation. But you will notice that the height of these P waves, the appearance of these P waves is not identical. So the next point is that this would be a variable amplitude of P wave. The clinical diagnosis on the basis of this would be multifocal atrial tachycardia. Please mention the chemical cardioversion agent that you will be using in this patient. Yeah, DC shock, doctor, I'll not say like this that DC shock is contraindicated. I'll just say that if DC shock is not recommended for these patients, in a sense that there is a recurrence. I mean, that would be an overstatement. I mean, it's okay. I mean, if I give DC shock, because most of the time these are COPD patients, the hypoxia in the lungs would, hypoxia due to lung damage would still be present. So even if you give a DC shock, I mean, there's a bound of recurrence in a patient. Yep, either we can give metoprolol or we can give verapamil in a patient. Considering that we are dealing with a person who's having COPD, beta blocker is something that I'll not be very comfortable with. So it would be a better answer for this question would be calcium channel blocker. We can use verapamil as agent for chemical cardioversion. Like we use verapamil for prevention in PSVT. But in this particular case, we are using it as an agent that will help in managing the case. Sir, we do not use DC shock in management of person who's having, and anyway, we have not asked for cardioversion anyway. Cardioversion, chemical cardioversion agent has been asked. So verapamil is to be answered. Okay, moving to the next one. Identify the rhythm and the chemical cardioversion agent. So this particular case shows sawtooth waves. What I can notice is presence of that classical sawtooth pattern. This would be a 3:1 atrial flutter. And the drug that I can use in this patient would again be for chemical cardioversion. I can be using amiodarone, or a class 3 antiarrhythmic like ibutilide can be used. 53 and 54 are sorted. This is not an atrial fibrillation because the RR interval is constant in this case. I mean, the RR interval is not changing. If you compare the RR interval serially or even subsequently, it's almost the same. I mentioned about amiodarone first because that is what is commonly available in our hospital. So class 3 antiarrhythmic would be used. Yeah, low intensity DC shock. I mean, for definitive treatment for atrial flutter, that would be a low intensity DC shock would be used. That would be a low intensity synchronized DC, 25 to 50 joules. That's the only time when you answer low intensity DC. Okay, the next one, you can notice that the heart rate of the patient is fast because there are approximately 2 large squares between the R and the R wave. Considering that the heart rate of this patient is hovering in the range of about 150, I just need to check that is it a PSVT or is it a sinus tachycardia. You can notice that the T wave of the patient and the P wave of the patient can be seen separately. So this particular case would not be called as a PSVT. The one that I'm showing to you at the moment is not a paroxysmal supraventricular tachycardia, because if it was a PSVT, then this T and P, they would be merged into a single one. This would be a ST, this would be a sinus tachycardia. This could occur most of the time due to anxiety or due to like smoking, taking large amount of coffee can trigger development of sinus tachycardia in a patient. Let's compare this with the next ECG. If you compare with the previous one, you will notice that in this one, there is some magnitude of, I'll just show that ST depression also, but the point is at this moment, even at this magnification, you are able to identify, okay, let me just use a different color to highlight that. I mean, what we are seeing is that ST depression and then a single wave can be seen in this case, unlike the T and the P that was seen separately. So this would be a PSVT, a paroxysmal supraventricular tachycardia. And the question says, what would you use for the treatment of this condition if the BP is unrecordable? Yes, Josephson sign is for patients who are having VT. This is PSVT that we're talking at the moment. A global ST segment depression can be seen. Even at lower magnifications, even if I zoom out of the image, you can still notice some magnitude of ST depression seen in this patient. That's because of sudden fast beating of the heart in a re-entry circuit created by PSVT. If the BP is unrecordable in this case, then we will not give adenosine. The question said, what will you do if the BP is unrecordable? Your answer is, I will do cardioversion. That is a synchronized DC shock would be used in this case. Let's compare this with the next ECG. If you compare with the previous one, you will notice that in this one, there is some magnitude of ST depression. Otherwise, the answer would have been adenosine. Why I have not said adenosine in this case is because the question says if the BP is unrecordable. So check out the BP values in all tachyarrhythmias. This we've already talked about a broad, broad QRS complex ventricular tachycardia. All the waves are almost of the same size. That would be monomorphic VT. Otherwise, we can use beta blockers in the patient as well. Even in this case, if it is going to be without blood pressure, pulseless case, we will have to go in for defibrillation in this patient. I have hand drawn this ECG already, but I hope I would be able to get answers for the 58th one that is currently on the slide. Yes, you are right. Josephson sign was visualized in the previous one. We'll give, no, sir, we'll not give amiodarone because the BP was unrecordable. Yes. Yes, guys. I can see a P, a QRS, and a T like this. And then what I can see is a R and then a broad S like this. And then there's a small T also. Yes, guys. Again, let me draw it. If you are still not able to pick it up, see this again, P, then R, then a T, some twitching. And then there is this nasty big broad R and that slurred S. I hope I have drawn it fairly accurately. I mean, you can notice the broad R and that slurred S that I've drawn here before you. So what are these? These are premature ventricular contractions and they're occurring alternative with normal sinus rhythm. So I had drawn this ECG earlier before you as well. This would be ventricular bigeminy. And ventricular bigeminy can deteriorate very fast into ventricular tachycardia. So if it is a ventricular bigeminy, the drug that I'll be using for the patient would be lignocaine. Yes, a bit of rabbit ear appearance is also present in this one. Yes, we can see the rabbit ear appearance here also. True. Why that is happening is because the routine conduction system is not being respected, no? I mean, the current is utilizing a abnormal focus, which is probably created by a drug. So that is why, I mean, the problem is occurring in this case. Okay, let's move on to the next one. Identify the rhythm while the CPR is being performed and what is the next best step for management of this patient. You can notice twitching all around the baseline. Why not amiodarone for ventricular bigeminy? Sir, they have done clinical trials and they have found that the certain drugs are working better in particular scenarios. So let's not challenge that. Okay, so we can notice a ventricular fibrillation in the patient and he's saying CPR is being done by your team. What will you do next in the patient? So what are you gonna do, guys? For any patient whose adenosine is for PSVT with BP recordable, Dr. Shreya. If PSVT BP is recordable, that is when we give, stable PSVT is where we give adenosine. We'll give defibrillation for the patient. This table should be, it should be imprinted in your mind that you have to give 3 shocks here, as you can see. And in the boxes, they will ask you if this table will come. I mean, if he will get into this, he will love to ask about what will you do subsequently. So what will you do after shock? You will obviously give a CPR. But what is the difference in the 3 boxes? We need to evaluate. The first box may what you'll do apart from CPR will be secure a IV line or an intraosseous access. In the second box, what you will do is that via that IV access, you will give epinephrine to the patient and you will be putting endotracheal tube. Advanced airway means endotracheal tube. I repeat once again. After every shock, what are you supposed to do? You're supposed to give two team members will be doing CPR to those, giving CPR 30:2 ratio. But the interventions that you need to remember would be secure IV line for the first box. If he says one shock has already been given, CPR has already been given for 2 minutes, IV line has already been obtained, but still person is having a presence of a shock refractory pulseless VT, what will you do next? Your answer is again, I'll give CPR and then give epinephrine to the patient and intubate the patient. And if these have also been done, then in the third box, you are giving amiodarone for the management of this particular patient. So the message here is that, I mean, why do you give epinephrine and why do you give amiodarone? The reason why you give have been discussed in the main section of the app. At the moment, in the end, I can just summarize is the summary I can say is that giving adrenaline and amiodarone makes the efficacy of the third, it increases the efficacy of the third electroshock. The simplest words I can say is, though I've gone into technicals like improving coronary perfusion, etc. The simplest I can explain is adrenaline and amiodarone in ventricular fibrillation / pulseless VT improve responsiveness to electrical shock in a patient. The correct answer for this one is VFib, and this table has been talked about. Similarly, they would mention about basic life support. You can check this in the PDF, and in the previous live session that I've taken on the same channel, I have talked about questions on the basic life support also. Routine data, you very well know, check scene safety, SRS, no? Check scene safety, R is responsiveness, then shout for help. S is scene safety, R is responsiveness, shout for help. Activate emergency response, then is procure AED. Get the points right. The point is activate emergency response, then is get AED. So there are two A's, SRS and two A's. But the difference between the two A's is that one is you are activating the emergency response. That is maybe asking somebody to procure a AED machine. And then is once you get the AED, I mean, one is activate emergency response via mobile phone. I mean, protocol has to be remembered. That's the point here. And total would be 100, doctor. So we are sorted for how many? We're done for 59, 40 more to go. The question says, what is the best treatment for this condition? You are noticing there is a tachycardia. The RR interval of the patient is substantially reduced. It's more looking like a supraventricular tachycardia, in fact, because the P and the T waves separately are not visible. But in this area, you can notice that there is a sinus pause. The presentation is that of the presentation in this case is that of bradycardia tachycardia syndrome. Bradycardia tachycardia syndrome is a manifestation of defective SA node. The person is having damage to his SA node. And for management of this patient, we would be putting in a pacemaker. Yeah, doctor, I'll try to finish before that only, because now the questions will be easier. We'll be putting a pacemaker. So the answer here is not a ICD. We'll be putting in a pacemaker for management of this condition. Yep. I'll count the number of squares in this case. The squares that you can count here are 1, 2, 3, 4, 5. So there's a bradycardia. The heart rate of this patient is about 60, or I can say a little around 60. There's a bradycardia. Yes, guys, what should I answer for this one? Would you like to answer 6 sinus syndrome, or would you like to answer sinus bradycardia? Quickly, in the comments, please. Sinus brady, or would you like to answer 6 sinus syndrome? Can you see a P wave here? Yes, I can see a P wave, because I can see a small deflection of a P wave present every time. I would not like to call it a 6 sinus syndrome. I would like to answer this as sinus bradycardia. There is no treatment required at this particular moment if the person is asymptomatic. And I mean, because the P wave is visible in this case, that is why the answer is sinus bradycardia. If P wave was not visible, we would have answered this as answered it as 6 sinus syndrome. Next is the standard image, where you will be able to notice a gradual prolongation in the PR interval of the patient, the first time, the second time, and the third time. And then after the P wave, there is a absence of conduction. I mean, after the P wave, you are waiting. There is no QRS complex, because there is a gradual prolongation of the PR interval in the patient. This would be an example of second degree heart block. And in this second degree heart block, we are going to call it a Mobitz 1 heart block. The easier way to solve this question is check out the PR interval after the drop beat. This is the drop. So if you're going to check out the PR interval after the drop beat and before the drop beat, you will be able to notice that the PR interval is unequal, which is why this is Mobitz 1 heart block. आप यहाँ देखो that this particular area and this particular area, the PR interval is not equal. Very good. Wenke-Bach phenomenon is an alternative name for this. We'll compare this with the second one. In the next one, you can notice that the PR interval of the patient is almost the same. You can notice the drop beat here as well. After the P, there is a sinus pause present in a person, because before and after PR interval, before the drop beat and after the drop beat, the PR interval is constant. This would be answered as Mobitz 2 heart block. Great, M2. Moving to the next one, I would like you to comment on the answer here. What I'm noticing is there is a drop beat here. This is the P wave. I'm going to check out the PR interval of the patient. I'm going to check out the PR interval of the patient before and after. Before I'm going to check the PR interval before and after, I can notice it is almost the same. So first impression of mine is this is also Morbitz 2 heart block. But the point is there is a pattern which is occurring in this case. The pattern what is happening in this case is this is a differential diagnosis of Morbitz 2 heart block, which is to be remembered. The bottom line is that here alternative conduction is occurring because you can notice a normal sinus rhythm, then there is a drop, then there is a normal sinus rhythm, there is a drop. This is a ECG which can look like that, or drop is the vertical arrow that I've shown after the P. When you have normal sinus rhythm, drop, normal sinus rhythm, drop, this is a differential diagnosis of Morbitz 2 heart block that is called as 2:1 block. So every time in the exam, when you're gonna check out Morbitz 2 is gonna be like 3, then a drop, 5 a drop, 10 a drop, 100 a drop, like that. It would be asymmetrical. Whereas here it is NSR drop, NSR drop. I repeat that again. For Morbitz 2, it could be like 10 beats normal, then there's a drop, then 15, then a drop, 100, then a drop, after half an hour, then a drop, asymmetrical. But here it's gonna be regularly occurring, which is why we would be answering this as 2:1. And the subsequent one, you will notice that the number of the P waves and the number of the QRS complexes are not matching. I mean, there are many more P waves present. P waves, I can count almost 5, 6 P waves, whereas I can count only 3 broad QRS complexes, 3, okay, maybe 4 QRS complexes. So because the number of P is not matching with the number of R waves, number of P waves and the number of R waves or the peak of the RS complexes is not matching, we will think in terms of AV dissociation, and this AV dissociation would be called as third degree heart block. So perfect. AV dissociation, absolutely. This is the particular condition where we go for a dual chamber pacing. The question says dual chamber pacing is done for, answer is third degree heart block, AV dissociation. The last ECG that I'm showing you has been discussed even earlier in this section only. I would like you to notice the change in the amplitude of the QRS complexes beat to beat variation. This particular patient is having blunt chest trauma, like he was driving a car without a seat belt. He has been admitted to my hospital with very low blood pressure, unrecordable BP or very low blood pressure. When I ran the ECG of this guy, I noticed that there was electrical alternance present. The ECG pattern is electrical alternance, and this clinical presentation is that of cardiac tamponade in a patient. Yep, very good. Then the findings of hyper and hypokalemia have already been discussed. I said them earlier also. I'll just say that peaked T waves, then you have is broad QRS complexes coming up, loss of P wave occurring. So, I mean, that's the standard feature. And then you get a sine wave pattern. That sinusoidal pattern is the sine wave pattern that would come up in a patient. Even if ECG is normal in a patient, if electrolyte report is abnormal, you still need to treat the patient with help of calcium gluconate. I mean, emergency management is calcium gluconate followed by insulin drip. Treatment of choice would be insulin drip. For hypokalemia, there would be opposite finding, and one of the findings which has been asked in NEET PG is pseudo P pulmonale. You very well know that P pulmonale is seen with pulmonary artery hypertension, but with hypokalemia, P wave will become bigger, where hyperkalemia, P wave will become smaller and will disappear. Next is flow volume curves. For flow volume curves, I want you to remember at least 2 minimal flow volume curves that I'm going to hand draw before you, and you can see I'm putting star mark here, single star mark versus double star mark, and you can comment for the single star mark initially while I draw it. The inspiratory part is fine, but during the expiration part, there is a scooped out concavity present. This scooped out concavity where I put a star mark present is for a person who's having obstructive airway disease. So this may be a patient of COPD or asthma. And how will I differentiate between the two will be that I will be giving a bronchodilator to the patient and I'll be repeating this curve once again. When I give a bronchodilator and if I'm going to repeat this test again, if I notice a change, the change would be like this. If I notice that this concavity becomes lesser, if this concavity becomes lesser, it means it is asthma, because COPD is an example of a non-reversible airway disorder. The change that should be demonstrated in the value of FEV1 before and after salbutamol should be at least 12%. We now look at where the double star mark is present. You are noticing that in this particular case, let me just hand draw this once again before you. You will notice that this is normal. and now this curve has become relatively more shrunken, and it's adopting a much more peaked appearance as well, which is called as a beanie cap appearance. This would be a feature that is seen with restrictive lung disease. So if a person is having pulmonary fibrosis, then the total lung capacity is lesser. That is why the curve is all restricted in this particular case and indicates interstitial lung disease. Though in the routine sections, we have talked about even tracheal stenosis, where you will have a fixed obstruction present. Like this particular case, the inspiratory part is also narrowed and the expiratory part is also narrow. This tells you that there is less air going in, less coming out. That would be tracheal stenosis in a patient. But at least the parameters for obstructive and restrictive, one should be remembered in flow volume curves. Coming to 70, he says, what is best to prevent thromboembolism in a atrial fibrillation patient with mitral stenosis? Then we have discussed, we will be giving warfarin in the patient. For non-rheumatic, we'll be using dabigatran and other molecules. Moving to 71, please answer. Wallenberg syndrome does not involve which cranial nerve? Wallenberg is lateral medullary syndrome. So the cranial nerves involved in this condition would be 5, 7, 8, 9, 10, 11. But this is not going to involve which nerve? The answer would be very good. Luffy was the first one to answer. This would be the 12th nerve. Great, great, very good. Because 12th nerve is involvement of medial medullary syndrome. The artery involved for Wallenberg syndrome would be vertebral artery. For medial medullary syndrome, the artery involved would be anterior spinal artery. So a quick look at, you read that in anatomy also, the blood supply for the various ones. Okay, moving to 72, elevated immunoglobulin E and central bronchiectasis in a patient would be a feature of Degerin, doctor, that Degerin Rousino, that is seen in a chap who's had a subcortical stroke, internal capsule, the sensory fibers getting affected. Yeah, doc, अभी पहले मैं ये questions करा देता हूँ. That would be more important at the moment. Very good. The key word in the question is central bronchiectasis. Every time you read this word, the clinical diagnosis of would be as allergic bronchopulmonary aspergilloma. This would be because of Aspergillus fumigatus, not Niger, which causes invasive aspergilloma. It is fumigatus which would be used. क्या treatment दोगे सर यहाँ पर? For allergic bronchopulmonary aspergilloma acute exacerbation, what would be used for treatment? You want me to give options? Posaconazole, voriconazole, steroids, क्या दोगे? Liposomal amphotericin B, voriconazole, posaconazole, steroids for acute exacerbation of allergic bronchopulmonary aspergilloma. सर स्टेरॉइड देते हैं. प्लीज रिमेंबर, यहाँ पर हम एंटी फंगल तो यूज करेंगे ही करेंगे. ये इन्वेजिव एस्परजिलोमा नहीं है जो अभी पढ़ रहे हैं. अगर आपको कंफ्यूजन हो रहा है तो आप एक बार दोबारा से पढ़ लो, वरना आप इन्फेक्शंस वाला सेक्शन देखो, उसमें मैंने इसको कवर किया. एस्परजिलस पे हर्डी 20-25 मिनट का वीडियो है. Sir, it is not to be answered as what a lot of guys are answering for treatment. I'm not discussing Aspergillus niger causing an invasive aspergilloma. It is allergic bronchopulmonary aspergilloma. ये जो होता है ये asthmatics में होता है. This is not that invasive aspergilloma जिसमें hemoptysis आ जाएगा पेशेंट को. This would be steroids. तो एक बार aspergillus वाला component देख लेना. Just revise aspergillus 20 minutes 2x पे solve हो जाएगा. चलो जी, नेक्स्ट क्वेश्चन प्लीज. हाइपरटेंशन विद हाइपोकोलेमिक अल्कोलोसिस, द आंसर वुड बी लिडल सिंड्रोम. लिडल सिंड्रोम इज गेन ऑफ फंक्शन ऑफ एपिथेलियल सोडियम चैनल. ये ज्यादा काम करने लगता है. If epithelial sodium channel will work more than normal, more water and more salt will come in the body. That more salt and more water will explain hypertension. But नुकसान क्या होगा? Simultaneously there is gonna be a urinary loss of potassium and hydrogen, and that urinary loss of potassium and hydrogen will be explaining that urinary loss of potassium and hydrogen will be explaining the hypokalemic alkalosis developing in this patient. Yeah, Dr. Cons would be an important differential. Absolutely, absolutely, doctor. I mean, Dr. Monica, you have a point there. Even Cons syndrome has to be considered here. Liddle Cons. But we can differentiate between the two on the basis of aldosterone values. Vipul, you're right. Differentiating feature would be based on checking out the aldosterone values, and aldosterone values would be increased with respect to Cons syndrome. Okay, ji. Moving to the next one. What is the leading vascular cause of development of lower GI bleeding in a patient? Chloride resistant metabolic alkalosis. Yes, for Liddle it is amiloride. वो यार मैं actually पुराने question discuss कर रहा हूँ इसलिए थोड़ा Liddle. बाकी yeah, Cons syndrome is a very good differential diagnosis as people answered. Great. Leading vascular cause of lower GI bleeding in a patient. Very good, very good. If a person is having lower GI bleeding, then the first cause to be thought of is always piles and hemorrhoids, but he is saying a vascular cause. So vascular है तो blood vessels का cause पूछ रहा है ना, तो the answer will be given as angiodysplasia of the colon. Peptic ulcer तो यार upper GI bleeding का cause होता है. लीडिंग वैस्कुलर कॉज ऑफ लोअर जी ब्लीडिंग. सर वैस्कुलर कॉज पूछा ना डॉक्टर साहब, आप वर्ड्स ध्यान से देखो ना. द क्वेश्चन इज नॉट व्हाट इज द मोस्ट कॉमन कॉज, क्योंकि अब एरर्स हो रहे हैं तो मैं फिर से लिख देता हूँ. इफ द क्वेश्चन सेज व्हाट इज द मोस्ट कॉमन कॉज ऑफ लोअर जी ब्लीडिंग, it is then that you need to think in terms of diverticular bleeding. That is when you think in terms of diverticulosis in a patient. But question तो vascular cause है ना, तो vascular cause would be angiodysplasia. Leading cause of upper GI bleeding with splenomegaly. So answer is again not peptic ulcer disease. सर वैस्कुलर कॉज बोला ना, वैस्कुलर कॉज मतलब वैस्कुलर malformation. इन क्वेश्चन नंबर 74 द सवाल इज वैस्कुलर malformation इन अ पेशेंट. Otherwise, the number one cause of leading GA cause of GA bleeding is diverticulosis. अब diverticulosis में hospitalization की requirement हो जाएगी. Piles में hospitalization की requirement नहीं होगी. Leading cause of upper GA bleeding would be upper GI, I mean that would be portal hypertension, which will cause development of esophageal varices. Very good. 75 is esophageal varices. लीडिंग कॉज ऑफ अपर जे ब्लीडिंग तो ठीक है, वो तो पेप्टिक अल्सर डिजीज है, उसमें कोई बड़ी बात नहीं है. दैट वुड बी ईदर द लेफ्ट गैस्ट्रिक आर्टरी और अ गैस्ट्रोड्यूडल आर्टरी दैट वुड बी ब्लीडिंग इन दिस केस. We'll be doing upper G endoscopy and then we'll achieve local hemostasis plus we do a bipolar cautery of the base of the ulcer. Okay, Ji. Next one, please. Deluphise is a vascular cause again of the stomach bleeding. No, that is a rare cause. Vascular cause नहीं पूछा. What is the first investigation to be done in a patient with melena for last 3 days and acute lower GI bleeding today? उसको मतलब पिछले 3 दिन से ब्लैक कलर का स्टूल आ रहा था और आज उसको फ्रेश ब्लड आया. तो what is the first investigation to be done? Very good. I'm having limited answers. Very good. Ambika, Lakesh. Yes, yes. Very good. Yes, very good. Very good. Okay, okay. What is the most common cause for melena? What is the most common cause of melena, by the way? Melena is an example of lower GI bleeding, but melena is example of lower GI bleeding, but the point is that what is the most common cause of melena? It is peptic ulcer disease, na? So if he was having minimal bleeding from the ulcer, पिछले 3 दिन से उसको ब्लैक कलर का पॉटी आ रहा था बिकॉज इट वाज मिनिमल ब्लीड फ्रॉम द अल्सर. आज उसको टोरेंशियल ब्लीडिंग हो गया. सो पेप्टिक अल्सर डिजीज कैन प्रेजेंट एज हेमाटोचीजिया आल्सो. सो व्हाट इज योर आंसर नाउ? इज इट स्टिल कोलोनोस्कोपी? Sir, even in the app, I've told you what is the investigation to be done in a case of melena. Do you do colonoscopy in a patient directly? First investigation in any patient who is having melena is not going to be answered by you as colonoscopy. The first investigation is upper G endoscopy, sir. ये तो सिली मिस्टेक हो गया. सर मलेना का जो नंबर 1 कॉज है वो तो अपर जी ब्लीडिंग होता है ना सर. तो हमें उसको थोड़ा थोड़ा ब्लीड हो रहा था अल्सर से, आज टोरेंशियल ब्लीड हो गया. आर्टरी का बेस, द acid is eating away into the wall of the blood vessel. That means a gastroduodenal artery का branch है. So it is causing torrential bleed in the patient. So I'll be doing a upper GI endoscopy in the patient. And if you go through the notes also, the number 1 investigation in any patient having a melena is gonna be answered not as colonoscopy, but should be answered as upper GI endoscopy. चलो जी अगले पे चलते हैं. लीडिंग कॉज ऑफ पोर्टल हाइपरटेंशन, ये तो आसान ही है. दिस वुड बी अल्कोहलिक सिरोसिस. Otherwise, it could be hepatitis C induced cirrhosis as well. या वही तो बता रहा हूँ यार कि जो अल्सर था ना, वो अल्सर ने ही तो हेमाटोचीजिया कर दिया ना. अल्सर का जो ब्लीड होता है, लॉट्स ऑफ टाइम ड्यूडल अल्सर may not cause vomiting of blood in a person. Duodenal ulcer might cause the blood to torrentially flow through the GI tract and can cause hematochezia. That's the point. Torrential bleeding, torrential मतलब arterial bleed can cause frank blood to come. Mostly upper GI bleeding will cause hematemesis, understandable. Coffee grounds vomit is understandable. But if it's a duodenal ulcer, then there's a possibility that it might cause torrential bleed in the lower GI also. Okay, I think I missed one. Yep. Best treatment to be done for a case of bleeding esophageal varices, vasoactive agents, endoscopic variceal ligation, टिप्स नाडोलोल. यस गाइस, हाँ जी वो तो करेंगे ना. हम ऑक्ट्रोटाइड देंगे बैंडिंग करेंगे, टिप्स करेंगे. तो अब चलो मैं सॉल्व कर देता हूँ। नाडोलोल जो होता है वो तो नॉन ब्लीडिंग वराइसिस के लिए होता है। टिप्स कब करते हैं? तो टिप्स तब करते हैं जब पेशेंट को रिकरेंट ब्लीड होता है। टिप्स इज अ प्रोसीजर विच इज यूजुअली डन आफ्टर रेकरेंस आफ्टर एंडोस्कोपिक वेरिसल लाइगेशन। तो आपने तो मुझे दो को बीच में बताना है। टिप्स इज डन ओनली इन केसेस ऑफ रेकरेंस। नो सर, यू आर पुटिंग आई मीन a shunt in the patient. That's a procedure that will require hospitalization. So the best way would be I would say same day admission, same day I mean जिस दिन admit किया उसी दिन discharge कर रहे हो. That is the endoscopic variceal ligation is the treatment of choice for bleeding variceal bleeding esophageal varices. Vasoactive agents तो देने ही होते हैं. Vasoactive agents are only given for 2 to 5 days ना. वेजोएक्टिव एजेंट्स दैट यू कैन यूज इज लाइक ऑक्ट्रोटाइड। हैरिसन में तो ऑक्ट्रोटाइड ही लिखा है, वो यूजलेस कंट्रोवर्सी में मत पढ़ना कि टर्लीप्रासिन देंगे या ऑक्ट्रोटाइड देंगे। हैरिसन में पहले ऑक्ट्रोटाइड लिखा हुआ है, उसके बाद में टर्लीप्रासिन है। वो फंडा यही है कि भाई अगर आपके पास में इन्फ्यूजन पंप नहीं है तो आप टर्लीप्रासिन दे दो, भाई बोलस शॉट में देना पड़े तो। अगर इन्फ्यूजन पंप है तो ऑक्ट्रोटाइड का इन्फ्यूजन चला दो। वेजो एक्टिव एजेंट्स को हम एडमिट करके आपने देखा भी होगा वार्ड में, दैट्स गिवन ओनली फॉर 2 to 5 days एंड दैट रिड्यूसेस द पोर्टल वेन प्रेशर। बट द पॉइंट इज आप ये बंद कर दोगे वेजो एक्टिव एजेंट्स को तो फिर ब्लीड स्टार्ट हो जाएगा। तो यू नीड टू कंट्रोल द वराइसियल ब्लीडिंग ना। सो दैट इज व्हाई द आंसर फॉर 77 अपर जी एंडोस्कोपी। ओके। Okay, doc. I'll speak mainly in English. The point is, for any chap with bleeding esophageal varices, nadolol is for non-bleeding varices. Tips is for recurrence. For vasoactive agents, we you give them for 2 to 5 days, then we stop them. And the advantage of that is that it will lower the portal vein pressure, but that's not a permanent solution for the case. I mean, the permanent solution would be a endoscopic variceal ligation in a patient. Let's not argue, guys. We are doctors. Let's why to fight about such a small thing, sir. Let's not pass any comments. Okay, my humble request. Just few hours before the exam here, why to have wrong wordings being used? Okay. Best for diagnosis of alcoholic hepatitis and determining alcoholism. I got a lot of it's okay, doc, it's okay, perfectly fine. I'll speak majority in English, only few words because it's my mother tongue. I might accidentally speak some words in Hindi also. I mean, that happens with you also sometimes, can happen with anybody. Okay, coming back. What is the best test for alcoholic hepatitis versus best test for determining alcoholism? You see, the point is, a lot of people who drink alcohol might say, I don't drink alcohol. His wife is saying, Roj pita. Wife says he drinks every day, and he says, no, I don't drink alcohol. So how do you determine whether the guy is a regular drinker? Therefore, for diagnosis of alcoholism, the answer is gamma GGT, that is gamma glutamyl transpeptidase. But for determining alcoholic hepatitis severity grading is done on the basis of discriminant score, or what is called as discriminant function. And one of the parameters that we always use in discriminant score in alcoholic hepatitis is SGOT. That's because that's where SGOT is present, where inside the mitochondria, where the alcohol is getting metabolized. And then he can ask you about treatment of alcoholic hepatitis. That would be prednisolone, that is steroids would be used. No, sir, we'll not use MELD in this particular case. MELD is to be used when there is a need for orthoptic liver transplantation. Like if I say a person is having a end stage liver disease and I want to check out whether he's a candidate for, I mean, he's having features of liver damage, but I want to enroll him for orthoptic liver transplantation, then I will have to do a MELD score in a patient and enter the data in a dedicated UNOS website, organ sharing based website. And based on availability, then this guy might receive a liver transplantation. Okay, yes, Madry's discriminant score. Very good, Kunal. Need for liver transplantation is decided on the basis of MELD score. Sir, we can use it. We can use carbohydrate deficient transferrin. Both are given in Harrison. First gamma GGT, then carbohydrate deficient transferrin. Then is written macrocytic anemia, MCV more than 100. So I don't dispute what you said, doctor. I mean, yes, but the way it is given in the book, I have described it. Yes, bilirubin, INR, and serum creatinine. Sir, child's classification is to grade the need for liver transplantation. Child score more than 7 and MELD score more than 17 are indications for admitting a patient for liver transplantation. In child score, the parameters are bilirubin, INR, and then there are 3As. The 3As to be considered would be albumin. If albumin is less, there would be ascites. And at the same time, these particular chaps would also be having encephalopathy that will cause asterixis. Here the components are bilirubin, INR, creatinine. And nowadays they also speak about MELD Na. In MELD Na, then if he says this word MELD Na, instead of saying MELD, if the question says MELD Na, then you also include serum sodium. That's because hepatorenal syndrome can occur in the patient also. So MELD Na would include the sodium component as well. Okay. Moving ahead. Then I would like you to also remember this table with respect to hepatitis B. The PDF will be present in the group. You have it in your notes also. What I want you to just quickly revise here is, all of you know about acute and chronic hepatitis. That's never a problem. Surface antigen positive versus IgM class of antibody to core antigen and IgG class of antibody to core antigen. So acute and chronic hepatitis of yours is sorted. I mean, this does not require any special effort on your part, but he can give you questions in which surface antigen will be negative. So there are three possibilities where surface antigen can be negative in the question. So let's look at those three possibilities. The first one would be if he's going to talk about IgM class of antibody with surface antigen negative, that is window period. So that window period part I've already explained, but in the app also, but the message is if surface antigen is negative with IgM class of antibody, normally it is surface antigen positive with IgM class of antibody, that's acute hepatitis B. If he will say surface antigen negative with IgM class of antibody, it is acute hepatitis B. The next one is important. He is giving you negative for surface antigen and IgG class of antibody to the core antigen is present in a patient. That means he had infection in remote past. And if it is going to be recovery from hepatitis B, then there will be positive to antibody to surface antigen also. You can see this is the protective antibody. No, antibody against surface antigen gives protection. Sir, I'll post it, the PDF in the group. Okay, let me just zoom it in. And I have to say it again. I lost the connect. There are three scenarios where there would be negative surface antigen. Positive surface antigen, no issues. Acute and chronic hepatitis B. Three scenarios for negative would be window period. Second is remote infection. Third is recovery. Let's first focus on window period. Window period is only when antibody is present. Only antibody present is IgM class of antibody to core antigen. So window period भी solved हो जाता है. अब बचा ऐसा एमसीक्यू जिसमें IgG class of antibody to core antigen will be positive and negative surface antigen. How will you say remote versus recovery? Then the logic to be used is recovery means that the seroconversion antibody is there. Seroconversion antibody is where in the zoomed part where you can see my arrow finishing, that is antibody against the surface antigen present. So when you're trying to work it up, there are 5 permutation combinations that are spoken in the last 30 seconds. Acute chronic, not a problem. Window period, again, not a problem. But the remaining two, the remote past and the recovery part, just have a glance at that. And I'm sure that you'll be able to solve these nasty ones also, which he, if he wants to give up in the paper as well. So, I mean, the top, there are 5 permutation combinations. 3 will not cause a problem for you. It is only the last 2 that I've said. थोड़ा सा practice की बात है, and it's gonna be recovery from hepatitis B, which is gonna be the main point for differentiating between remote past versus the recovery part only. Okay, guys. Sir, it's a 15 minute का video, hereditary hyperbilirubinemia 2x पे सुनोगे, 7.5 minutes you'll be able to do that Dubin Johnson Kriegler-Najjar thing. Okay, moving to 82. सुपर इन्फेक्शन एंड को इन्फेक्शन. ओके 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 सर, अब इन्हीं के हिसाब से मैंने इसको प्रिपेयर नहीं किया एक्चुअली. आई एम फोकसिंग ऑन द नीट पार्ट हियर. ओके, Wernicke's encephalopathy, but Dr. Akshay, you can mail me at marvamedicine@gmail.com and I'll try to clarify the query, which I'm not addressing at the moment. Okay, Wernicke's encephalopathy, what is the area of the brain? Alcohol पूछना ही पूछना है उसने. Wernicke's encephalopathy will come. Sir, mammillary body is answered for Korsakoff psychosis. No, if you read, I mean, this is what we traditionally read. MRI is showing a mammillary body atrophy. That is mainly a feature that is seen with Korsakoff psychosis. I'm asking about Wernicke's encephalopathy. It's not that you are wrong, but there is a slight technical aspect that mainly in Wernicke's encephalopathy. PDF will be available in the PrepLadder Telegram group as well as in my Telegram group, or you can email me at marvamedicine@gmail.com. Okay, ji, Wernicke's encephalopathy, the area of the brain involved would be answered as the thalamus. Your answer would be dorsomedial thalamus. It's not that we are not going to have an involvement of the mammillary body. Yes, we have it. But your first answer for Wernicke's area is dorsomedial thalamus getting affected. Yes, Zen mode, you're right. Then is apolipoprotein associated with development of Alzheimer's diseases, apolipoprotein E. It is apolipoprotein E, which is related to Shoaib. I'll come to your point that this is not, it's not Wernicke's aphasia. Absolutely, absolutely. I think a lot of people were thinking Wernicke's aphasia, Wernicke's encephalopathy. Then this apolipoprotein PDF will be available in, okay, you can mail me. I'm writing my email ID here, marwamedicine@gmail.com. चलो जी आगे चलते हैं. Which variant of apolipoprotein E is protective for Alzheimer's disease? What you are answering me is very correct. The epsilon 4 variety of it is leading to Alzheimer's disease, and the one that is protective would be epsilon 2 variety. 2 number कम है, protective है, 4 number ज़्यादा damage कर रहा है. Good, 84, 85 sorted. Okay. Entry level, यार देखो सबका तरीका अलग अलग होता है ना. Some people like to listen, some people like to read PDFs, so let's not be nasty to each other. Entry level criteria for diagnosis of SLE. SLE word रह गया. Entry level criteria for diagnosis of SLE. Quickly guys, what test would you do for, entry level criteria for, you can answer clinical criteria, you can answer lab criteria. Yes, yes. Anti-nuclear antibody, absolutely. 1:80. Right. Fine, great. Best screening test for scleroderma, guys. Yes, yes. Nearing the end of our discussion. Very good. Anti-nuclear antibody is sorted. I'm looking for 87 answer. What is the screening test for diagnosis of scleroderma? The answer is still anti-nuclear antibody. But if he says what is the investigational choice for scleroderma, then your answer will change. Yes, then the answer would be given as topoisomerase antibody. Antibody list, a quick revision would always be warranted and would help you, sort those names easily. No, sir, we'll not do anti-Smith there. Anti-topoisomerase for scleroderma. Centromere is for C, se na? Here, anti-centromere is for CREST syndrome, no? Anti-centromere antibody. The C alphabet to be remembered for CREST syndrome. Calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasias. Okay. Okay, few rheumat ones left. Most common extra-articular manifestation of rheumatoid arthritis. Yes, guys. For rheumatoid arthritis, extra-articular manifestation would be ANA. We are sorted. For limited, it is centromere. Yes, Amreen, you're right. Absolutely. The extra-articular manifestation would be a rheumatoid nodule. They would be found on extensor distribution. Okay. Then is ocular involvement of rheumatoid arthritis. No, guys, it is not uveitis. I have explained that also. No, it is not uveitis. I've told this multiple times. Even in the last session, we had a chat about it. कि सबका uveitis बोल देना sarcoidosis में, ankylosing spondylitis में, but यहाँ पर uveitis नहीं बोलना है. No, sir, it is not. It is keratoconjunctivitis sicca. It is not even episcleritis. In rheumatoid arthritis, the ocular involvement was discussed even in our last time's discussion, in the last live we had, that it is keratoconjunctivitis sicca. It is not to be answered as uveitis. For others, you can answer the uveitis, that is okay. But yeah, uveitis is seen with joy. That's a good point. I think Dr. Kennel mentioned that uveitis component will be answered only for juvenile rheumatoid arthritis, but not for adult version. Okay, guys. What is the drug of choice for mild to moderate Crohn's disease and then for moderate to severe Crohn's disease? Yes, yes, guys. Crohn's disease, we do we classify Crohn's disease severity activity index. Yeah, steroids will be used. Azathioprine, I'm getting steroids. For mild to moderate, sir, it would be answered as budesonide, ileal release preparation. But if he says what is for severe Crohn's disease, then answer would be given as prednisolone. But if he says fistulizing, fistula present, then what medicine will you give for what will you do for multiple fistulas in person with Crohn's disease? Options are referred to surgery, treat medically. Very good. You will be starting the patient on infusion of infliximab. In Crohn's disease, if it is mild to moderate, we give ileal release preparations. If it is severe, oral steroids are required. If it is multiple fistulas, we'll not refer for surgery because अगर हम surgery करेंगे तो there would be recurrence at the site of wherever the person has been operated upon, plus the gut wall is friable. So for healing of ulcers, we'll go in for infliximab infusions. But before we give infliximab infusion, we must rule out possibility of tuberculosis in a patient. So the question said, which test must be done before giving infliximab infusion in a patient who's having fistulizing Crohn's disease? Then we should be doing is a TB gold quantiferon test. If we do not have TB gold quantiferon, then no issues. We can do a Mantoux test also. That would be a purified protein derivative based test. But tuberculosis is a big time risk with reactivation of TB is a big time risk with usage of these patients. Mesalamine is only for supportive management in these patients. Primary agent would be steroids in Crohn's disease. Sulfasalazine and sulfasalazine तो सर ulcerative colitis में ही आता है सिर्फ. We do not give sulfasalazine to patients who are having Crohn's disease because sulfasalazine acts only on the colon and mostly in Crohn's it would be small intestinal involvement also. So your answer would be given as mesalamine. We have a controlled release preparation or we have a delayed release preparation. This is used in Crohn's disease in a patient. That is again for mild to moderate variety along with ileal release preparations. Okay, ji. Moving to the next one, which is the most common cause. Sulfasalazine is only for ulcerative colitis. Most common cause of pneumonia in a AIDS positive patient would be, the answer is pneumococcus. As I've explained, whether he says pneumonia, whether he says lobar pneumonia, the answer is always to be given as pneumococcus and not as pneumocystis jirovecii. Sir, most common cause of pneumonia. I'm getting tuberculosis as answer. I'm still getting jirovecii as an answer. I've explained this a large number of times. AIDS person will also be living in community. If he will live in community, he will develop community acquired pneumonia. So the answer is still pneumococcus. Jirovecii should be answered only when he selectively mentions regarding X-ray findings in a patient. I mean, when would you answer jirovecii would be the query in your mind at this junction. So let me just resolve it for you. One possibility is he says X-ray of the patient is turning out to be normal, but when the doctor checked alveolar arterial gradient, the alveolar arterial gradient in the patient was grossly high. Or he says bronchoalveolar lavage of the patient shows presence of specific organisms which you guys are describing as balls or hockey balls or whatever. And along with that, obviously, because it is an opportunistic infection, the CD4 count of the patient will be given to be low. So only when you start getting these kind of information in a question that you should think in terms of jirovecii. Otherwise, routinely, it is not jirovecii, it is pneumococcus. Sir, we'll use steroids in any patient where there is problem with sulfa drugs. Na? Sulfasalazine में जो active moiety is sulfapyridine. Paritosh said person is having problem with sulfasalazine. The problem is sulfapyridine. So either I can, even in that chap, I can be using a controlled release preparation of mesalamine. If he still can't tolerate that, I'll be using steroids. Black fungus is not mucor. Is not mucor, sir. कितनी बार तो हो गया ये डिस्कस. Black fungus is not mucor. It is demitaceous fungi. Mucor नहीं है भाई. Repeat question है ये. Black fungus is demitaceous fungi. They produce melanin. Black fungus is a misnomer for black fungus is a misnomer for mucor. I think, I mean, इस stage पे जाके will not fall into this trap. But I think it's clear for everybody that black fungus is a misnomer for mucus. Investigation of choice for neurosyphilis, quickly, please. Yeah, demitaceous fungi. Quickly, guys. The investigation of choice for neurosyphilis would be CSF VDRL. We'll not use benzathine penicillin in this case, guys. We'll be using in this particular case penicillin G intravenously. Benzathine penicillin is used for primary syphilis, but for CNS syphilis, it is penicillin G because we need a CNS penetration to occur in a patient. Most common site of gastrinoma, I mean, I know it is a gastrinoma triangle, Pasaro's triangle, as you know. Boundaries I'll mark before you while you guys give me the answer for most common site of gastrinoma. You will start from junction of the cystic duct where it meets with the hepatic duct. Then you will join it with area where the head and the body of pancreas are meeting. And then you will dissect it at where the second and the third part of the duodenum are meeting. I said 3 points: junction of cystic duct with hepatic duct, then is gonna be head and body of pancreas and second and third part of pancreas where they're meeting. These are the 3 points which have to be remembered for the anatomical location of gastrinoma triangle. The most common site would be the duodenum, and this person would be having refractory peptic ulcer. He will be having giant duodenal ulcers. Whenever you read about refractory duodenal ulcer, giant duodenal ulcer, or duodenal ulcer at the second part of duodenum, sometimes even in the third part of duodenum. With H. pylori, you never read about a peptic ulcer at second or third part of duodenum. But if you're gonna read it in the first part, no sir, not first part of the duodenum. If you read an ulcer in the first part, I'm talking about ulcers there. The ulcers are gonna be the ones which are considered. Okay, what test would you do for anatomical localization of a gastrinoma? Best test for any tumor localization is PET-CT. Best test for any tumor localization is PET-CT. The best answer would be PET-CT, that is gallium-68 dotatate. However, if PET-CT is not given, then you will answer as endoscopic ultrasound. Otherwise, no issues. For whether, even if he says pheochromocytoma, no? If he says what is best test for localization of a best test for localization of a pheochromocytoma, I have told you MRI in the routine videos, but point is that MRI localization is very, very less. If a tumor is very, very small, then you may not be able to identify, or you may not be able to pick up the tumor. So that the answers are the way I have mentioned. We will use PET-CT dotatate is the best one, endoscopic ultrasound subsequently. Absolutely. Okay, coming to the remaining few ones, owl eye inclusion in a urine cytology. Yes, especially at Zucker candle location, extraadrenal, PET-CT would be very good. Owl eye inclusions in urine cytology of a renal transplant infection indicates cytomegalovirus. These would be basophilic inclusions. And this will contribute to graft failure in the patient. The not a criteria for diagnosis of metabolic syndrome. In metabolic syndrome, we take into consideration elevated triglycerides. We take into consideration low value of HDL, but people are still answering cytomegalovirus. Yes, not a criteria for diagnosis of this would be high LDL. We will be having obesity in this patient, that is centripetal obesity, for which abdominal circumference criteria will be used to 90 and 80, 90 for a male patient, 80 centimeter for a female patient. You'll also be having hypertension in these patients. There will also be impaired glucose tolerance occurring in the patient, but you will not have a high LDL. It is increased triglyceride and low HDL in the patient. Great. Okay, ji. Then we come to the remaining last two questions here. Inhaled nitric oxide is used for management of which of the following? Quickly, guys. Inhaled nitric oxide. Okay, somebody answered from the back. Yes, pulmonary artery hypertension. Absolutely, we use inhaled nitric oxide, or we can use inhaled prostaglandins also. And let's do the honors with the last one for today. 101 बताएं आपको, 100 की जगह मुझे 100 number. I'm a little, what you can say is, I like 101 more than 100, so I thought it make it 101. Though I can continue more than that also, but I think you guys might be exhausted. Which of the following is used for management of sideroblastic anemia? Yes, guys. Your repeat question. Vitamin B6, so we call it pyridoxine responsive sideroblastic anemia. Well, guys, this would be the end of the discussion for today. This would be my email ID in case you have any last minute issues. If I can help, I'll try to. And for the PDF, we'll post that in the PrepLadder Telegram group or in my Telegram group as well. And it's been great serving with all of you, honor working with all of you. And I am very sure that post this phase, all of you are gonna be having big smiles on your faces. Doctors always have some troubles in their life, that's okay, चलता है. But then हमारे लिए तो छोटी छोटी खुशी यही होती है, एग्जाम हो गया. We are not the kind of people who would be happy with buying a BMW, Merc. We are happy with simple good food, comfortable life, in a sense that at least stress now, yeah, tension now. So you guys, sir, first line answer is it's pyridoxine responsive anemia. Sir, you can go through the lecture part for understanding the pathology behind it. So God bless you guys. I'm very sure all of you will do great in your life, and I am speechless with all the nice words that you guys are doing. I'll post this, guys. Thank you so much. Thank you so much. Thank you so much. Dr. Amulya, Avinash, Shushma, Jawahar. I have missed a lot of names. I'm really sorry for that. Dr. Bhavin, Neha, Dr. RK, Dr. Meena. Thank you guys. God bless you. So let's wind off the discussion for today. आप थोड़ा सा और आज आप मतलब I think आज सो लेना ठीक से. Sleep well, sleep tight for 8 to 9 hours, and tomorrow, depending on whatever you feel like, I mean, you can just turn around the pages. I understand दिमाग में ज़्यादा नहीं जाता. But my only advice is think it as a routine exam. ज़्यादा pressure नहीं लेना है. मतलब होता है pressure, but then reach the center on time. सुबह मतलब rush ना हो. Check out all the Google Maps etc. for any local protest in any city etc. That can cause a bit of problems. My one message to all the people will be that success अपने time पे मिलता है. Success is something which nobody can prepone or postpone. Everybody gets it on time, right? And I have never seen a doctor not being able to. I mean, there are problems. I understand residencies, pressure, everything. But एक limit के बाद में ना, you tend to become immune to all of that and start doing good in your career. You start getting the flair of picking up things, and you start thinking, okay, I'll do independent my thing. So I don't think so that we need to be having any negative overview with respect to our careers. I mean, लगता है at this stage I understand everybody thinks कहाँ फंस गए यार, others are earning more and other people are enjoying and we are studying, but then you guys are destined for this only. I think so. This is my advice for you guys. Okay guys, thank you so much. I can continue the chit chat and this will waste your time. So God bless you. Take care. Bye bye.